Sam, I believe you're muted. You're still muted.
Oh, well, there we go. Yeah. See? Hold on. So for those of you who are online, if you could just give us a moment, we suddenly had a wave of people who showed up, and we just want to make sure that we give them an opportunity. Okay, here we go. Perfect. So just bear with me for a second, because I have to tell you that this is particularly a special month for us here at the foundation. And so, which makes this symposium particularly exciting for me. One is because I get to work with a great group of professionals who I highly respect, and they are starting off our symposiums this year in melanoma. The reason why this month is particularly important for the foundation is because it's our 20th anniversary this month. For those who are not aware, it was in 2003 that my sister, who was 25 at the time, was diagnosed with stage 4 melanoma. My mother, who founded the foundation, was president for many years, started this foundation because when my sister was diagnosed, the overall survival for patients in melanoma was 9 months. There was only one FDA-approved treatment at the time. There was very little in the way of support and in research. And so when my sister passed away, she wanted to make sure that no one ever had to go through what they had gone through. And so her mission was, number one, was to bring research to this field, develop, collaboration, and educate the melanoma community. 20 years is a long time, and it has, again, I am incredibly honored by the fact that I now get to lead this foundation, and we are the largest international foundation in the skin cancer community. And to not only, one step further, is that not only do we have many treatments that have been approved, in fact, coincidentally, actually, there was another treatment that was approved for stage 4 melanoma, which continues to show us that there is hope, that we are so close to a cure. In fact, there are many patients, unlike my sister, who many years out, who were originally diagnosed with stage 4 melanoma, are now living amazing lives and are doing incredibly well. And so again, this is why this month is particularly, I think, incredible for us, is because we get to start off the symposium season doing something that was unimaginable 20 years ago. So thank you for giving me that moment to share with you why this symposium is so important to me professionally and personally. I want to thank, again, the UC Melanoma and Skin Cancer Consortium for opening up these symposiums this year. I also want to give a special shout out to Paige Soaps, who has done an amazing work on the back end. There's lots of individuals who have done so much to get this thing off the ground and who go unrecognized. I want to mention the volunteer, Sammy, Safi, Ella, my colleagues at the foundation, Anne and Eric, and everyone else. And of course, all of you who are joining us in person and online. Thank you for sharing this moment with us and for doing so much to support the community. I just want to go over a couple of quick logistics. I promise I'm going to be very, very brief. There's an agenda in your folder. If you're joining us online, you can, follow the agenda that way. We strongly encourage questions. That is what makes these events so important, is that we get to answer your questions. If you're joining us in person, in your folder, there is a pad of paper. I hope you have a pen. If not, we can get you one to ask your questions. If you're online, you'll notice there's a Q&A. Please make sure to put your questions in the Q&A and not in the chat. We will get to your questions as best we can. Chats are great for giving a shout out to each other. And also please make sure they are general in nature. We are trying so hard to protect your privacy, and we are, this is live and virtual. If you're here in person, there's parking. Please make sure you have a voucher. And then one last thing, these events are, we can only make them better by getting your feedback from you, whether here in person or answering the survey. Again, that is our mission, to do whatever we can to help support you, and knowing how we can do a better job is an important part of that. So without any further delay, I'd like to pass this over to Dr. Daniels.
Thank you, Sam, and thank you for AIM letting us do this. It's always fun having friends come in from, we have UCLA, UCSF, UC Irvine, and patients and family who have come to support each other. So with that, I just want to take a moment to hopefully effectively share my screen. There we go. And as Sam said, UC Melanoma Skin Cancer Consortium is an effort that tries to bring together the UC schools in a collaborative way, because we're at a crossroads, most of us feel in melanoma, that to make more strides, to make bigger strides, we have to kind of pool together to keep pushing things forward. And as Sam alluded to, things are changing rapidly. And I'd like to say it's getting easier, but it's getting a little bit more complicated. For example, the cell therapy really has origins back in 1980. And many people have worked on this, but Steve Rosenberg really was the pioneer and pushed it forward at the National Cancer Institute. But one of the reasons why it hasn't been widely available has just been the complexity of it. And thankfully, it's been spearheaded to become more available. So FDA just approved it yesterday, and we're anticipating that this could be an option for that set of patients who have gone through standard treatments and still are battling melanoma, and this could be an option. So more to come on that, and we will happily answer all the questions at the roundtable on this new therapy. So you have the general outline for what we're going to go through. Luckily, it's not me speaking, it's experts from other institutions talking about origins of melanoma. We'll look inside and do a little uveal melanoma, and then talk about current management for advanced melanoma, and finally end with looking towards the future for melanoma care. So what is the UC Consortium? So there are comprehensive cancer centers at not all the UC campuses, but here are listed the 5 that have them. And there are mechanisms that the UC has put in place to facilitate interactions between us. Because as we know, healthcare is getting more and more complicated, and cancer is becoming more and more of a problem. So trying to leverage the expertise of the UC system to help patients, not just in California, but across the world. So this is their mission statement, again, trying to focus on collaborations. And you'll see that UC melanoma skin cancer is relatively new, 2022, but I like to think we've made the most progress. So the heme malignancy group led it off, and pancreatic cancer, lung cancer, and now skin. So we're really excited to be part of that. And some of the things that they bring to the table to have a collaboration are centralized operations, and again, ways to collaborate to make it more efficient. So advocacy is a big part of this. And so again, we're really happy to have AIM here. Talking about 20 years was when I started here at UCSD and doing melanoma. So we've grown up together and seen a lot of changes, and having these advocacy times where information can be shared and we can field questions. Because as Sam said, we can only get better by hearing what's going on. So with that, I echo Sam's thank yous. So thank you, AIM. Thank you, Paige, and our speakers who braved the traffic to get down here, or the plane rides, and of course, all the people that came in person. So, and online's value too. I'm going to stop sharing for a second and invite Dr. Linden up, who's a dermatologist up at UC Irvine, who's going to go through basically what most of us think about in melanoma, but emphasizing that the one way that we've shown to really help people have improved outcomes for melanoma is recognizing melanoma early. And so with that, Dr. Linden's going to tell us how to do that and more. I did that right.
Thank you, Dr. Daniels. I want to thank you and AIM for inviting me to speak. I'm actually going to talk about the making of melanoma. How does melanoma originate in our bodies? So, and, why do people get it? Why do we get melanoma? Why do we get other cancers? So first off, I think we have to start out at the basics. What is melanoma? And you're probably going to say, Dr. Linden, come on. I've had melanoma. I know that melanoma is skin cancer, but I want to look at it a little bit more depth. So we'll start at the tissue level here. This is the skin, right? This is like across the room diagnosis for a melanoma. This is melanoma of the superficial spreading type, very, very common type of melanoma. Like I say, this is a nasty looking one. Here's one a little more subtle on the nose here. And you might think this is just a sunspot, but it's got some dark features here. And the person doesn't have anything else on their body. We kind of call this the ugly duckling sign when you see something that stands out that's pigmented. Now, like I say, it's got some black areas that always catches our attention. That's a lentigo maligna type, a sun-caused type of melanoma. So it's a little bit different than the superficial spreading type. This is an interesting type. It's called acrolentiginous. It starts in the palms or soles or under the nails. This is a toughie because a lot of times, probably like in this patient, they just thought, I got some nasty fungal infection under the nail here. This one started under the nail. But you can see it's already spreading proximally here up the thumb. That's a bad thing. Acrolentiginous is interesting also because it affects certain populations. People of Asian descent or Black people will get preferentially, if they get melanoma, they're usually going to get an acrolentiginous type. It's either going to be in the palms, soles, or under the nails. And we're going to talk a little bit about the genetic makeup of that in a little bit later. This is a really interesting one here, this particular melanoma. It started out either as superficial spreading or lentigo maligna type, and that's what the bulk of it is. But here in the center, it's different. There's one cell probably. It's probably one of the melanoma cells went on and further mutated. That's basically one of the properties of cancer is once the cancer is formed, those cells become more able to mutate. And so you get more and more mutations as cancers go further and further in growth. And this one mutated into a form of melanoma called a nodular melanoma. This one's a little bit trickier because they tend to go down deeper faster. This one probably spread out here and was just pretty shallow the whole time, but once it changed, it starts going down deeper. And we know the depth of the melanoma, the deeper the melanoma is in the skin, the more chance it has of spreading to other parts of the body. So don't really like nodular melanomas at all, but that just shows how melanoma can change. Not everything is melanoma. This is an atypical mole, so it's a precursor to melanoma. This may or may not go on and form a melanoma. But that's not a melanoma. Not all brown spots on the skin are moles or melanoma. This is not even a mole. This is seborrheic keratosis, a completely benign growth. As decades go by, you start getting more and more of these, and you get in middle age, and more decades, you're getting it more. And so that's a seborrheic keratosis. So it's going to be kind of tricky to tell. I mean, it's got a powdery scale. It's not black. Here's another seborrheic keratosis, another benign growth. So these are kind of usually yellow-brown kind of lesions. Again, there's no black in them. So not everything that's pigmented on the skin is either a mole or melanoma. Here's a sunspot called a solar lentigo. It's basically a benign lesion in response to the sun. So let's get back to the question. So we talked about what is melanoma at the tissue level. Now let's dive down deeper. Let's look at the cells and the genes and the molecules that make up melanoma. So melanoma is a kind of cancer that starts in melanocytes. Well, what are melanocytes? Melanocytes are a pigment-producing cell of the skin. Basically, they are the pigment-producing cell of your skin. They give your skin its background color. So they're producing, and if you get a tan, they're the cells that basically crank up and produce more melanin so that your body tans to try and prevent you from getting more sun damage. You might think, oh, tan then is good. Well, it's only so good because when you get the tan, that indicates your DNA has been damaged, because one of the signals for forming the tan is basically your DNA has been damaged, the cell repairs it, cuts out that damaged part, and that damaged part that's been cut out is a signal to tan. So melanocytes are in the skin, but they're also found in other tissues of the body, interestingly enough. So you have pigment cells in other parts of your body. They can be in the eyes, and the talk after this is going to be talking about ocular melanoma. GI tract, from one end to the other. So from the lips on down to the other end. GI tract. Even places like the gallbladder, there are cases of primary melanoma. The melanoma started in the gallbladder. And you think, gosh, I don't have enough to worry about because melanoma's on the skin. Now I have to worry about it inside. Well, luckily, melanoma on the inside is very, very rare. So yeah, you have to worry about other cancers a lot more that are internal cancers. Genital urinary system also, we'll see melanoma because they're melanocytes. Let's look at the skin a little bit more detailed here. Here is a diagram of the skin. Up here you have the epidermis, this upper layer. Then you have the dermis, the lower layer of the skin, and then you have the layer below that that's usually fat. This is the fat globules sitting down here. Well, let's look at the epidermis. This epidermis actually here is only 2 paper sheets thick in reality. So this is a very, very magnified view. And these little brown things that look like octopuses, those are the melanocytes. And these little arms on them are called dendrites. And those dendrites basically feed melanin to the keratinocytes, all these other cells. The vast majority of cells in your skin are these keratinocytes. That's the bulk of your skin. But the melanocytes are down here feeding the melanin to protect those keratinocytes and your body and your skin from the sun. This is actual skin. This is cut in cross section. So up here you have the surface of the skin going along there. Then this is the epidermis. And again, this is only 2 paper sheets thick in reality. So this is highly magnified view. Then down here at the base, you have all these little melanocytes. And you can see the arms on them. They're called dendrites. And those dendrites, again, are feeding melanin pigment to the keratinocytes to help protect them and the rest of your skin. And there's about 1 melanocyte for every 8 keratinocytes. So 1 melanocyte for 1 pigment cell for every normal skin cell. And you can see these keratinocytes have taken up melanin here throughout the skin. And so they're helping shield the skin from the sun. So when certain things go wrong with this normal functioning of the melanocyte type of cell, melanoma can form. What are some of the reasons things can go wrong with the melanocyte? Well, you can have inherited reasons for things that are wrong with the melanocyte, and then you can have acquired reasons that things go wrong with the melanocyte. Let's look at some of the inherited causes for problems with melanocytes that might lead to melanoma. So we all know that we're born with a certain set of genes. And depending on the particular genes you have, they may have a propensity to form specific types of cancers, or they may you might have a complement of genes that make you more resistant to forming cancers. For melanoma, some of the inherited risk factors are errors in genes that regulate and control cell growth. Cancers grow out of control. That's the problem with them, right? They're not growing in a normal fashion in your body. The cells are not growing in a normal fashion. So genes that regulate and control cell growth and replication, those are very, very important. And if you inherit a gene that makes it more that your cells are not very well regulated, then you might form melanoma. Fair skin makes you more susceptible to forming melanoma for several reasons, including that the fairer your skin is, the less natural built-in sun protection you have. Tendency to form multiple moles, including atypical moles, and this can also be related to the genes that regulate and control cell growth. So that's the biggie. These are kind of side effects of that. So if you have a lot of moles, particularly if you have a lot of atypical moles, you're more likely to form melanoma, and that's basically some tendency that you were born with, most likely. So you can not only have errors in the genes that regulate and control cell growth, but you can have errors in the pathways that repair genes and cells. Some people, they've had a ton of Southern California sun, and they come in and I say, where'd you grow up? And they said, I grew up in SoCal on the beach, and I can't believe it, because most of the people that I see in my clinic, they grew up in SoCal on the beach, and their skin has a lot of problems with skin cancer. But these people must have super repair genes, you know. But if you don't have super repair genes, then particularly if you have problems with your repair genes, then you're going to have even more problems with forming cancers. And we see this all the time, that some people will form skin cancers very early in life. A family history of melanoma or certain other cancers can make you at more risk for inheriting susceptibility to form melanoma. Inherited errors in the immune system that make it less able to detect and eliminate melanoma and other cancers. So the immune system is pretty good at detecting problems in the body, including cancer. But if your immune system just has some problems with it from the genes you inherited, then you're going to have more chance of getting melanoma. Okay, so let's say a person is born with perfect genes. If the genes have no errors, then I don't think you can form melanoma, basically. But you're born with the perfect genes, so you don't have to worry about that. But then things can go wrong with these melanocytes throughout life. Damage to the genes and cells by environmental insults. Well, the main environmental insult is sunlight for melanoma. Obviously, sunlight's not causing breast cancer, colon cancer, prostate cancer, things like that. But it is causing melanoma and skin cancers. Other environmental insults, such as radiation. If you worked in a field where you got exposed to a lot of radiation, that's going to cause mutations in your cells and increase the risk of melanoma. Random mutation cells. Cells divide, your body counts on your cells dividing and replacing the cells that are worn out. And as they divide, things can go wrong in the division. And you can get oncogenes or tumor suppressor genes being mutated, and you're off to the races with the formation of melanoma. Immunosuppression. Some people, they need kidney transplant. Well, they get a kidney transplant, and then your body's ability, so that you need to take powerful immunosuppressives to keep your body from rejecting that kidney that you were fortunate to get. Well, then your body's ability, the immune system, to find the cancers when they're just forming and get rid of them before we even detect them is interfered with. And so this is even more a problem with squamous cell carcinoma of the skin, as Dr. Wong knows. What it means is that for a person with squamous cell that has a kidney transplant, they're like 20 to 40 times or more likely to get squamous cell carcinoma of the skin. Melanoma, it's increased, but not that high. So inherited and acquired risk susceptibility factors, errors in genes that regulate and control cell growth. Let's go back to that and talk about that in a little more detail. We're going to talk about oncogenes and tumor suppressor genes. These are hugely important in the field of cancer research, development of cancer therapeutics, treatments for cancer. Oncogenes, and this was by G. Steve Martin. He was actually at UC Berkeley. which I think is really appropriate since this is a UC Consortium event we're at. So Steve Martin at UC Berkeley, he identified the first actual oncogene. It had been hypothesized before that. But these genes, if they're activated, they lead to growth and multiplication of cells and resistance to the normal processes that keep cell growth controlled. So this is kind of like the gas pedal of a car. If you activate the oncogene, it's like pressing on the accelerator of a car. And those cells are, if you activate the oncogene, those cells are going to grow faster and they're going to replicate faster. And so it's basically, you turn on that oncogene, it's like just putting the pedal to the metal on the car, and then it gets out of control. Tumor suppressor genes are the opposite. They're kind of like the brakes of a car. These genes that control cell growth and multiplication, so they kind of put the brakes on growth and multiplication, that you want your cells to grow and multiply at just the right amount to replace the cells that need replacing. If you mutate a tumor suppressor gene, then it's like you try and put on the brakes, you have no brakes. Well, that's not a good thing in a car. It's not a good thing in a cell. So these two types of categories of genes, oncogenes and tumor suppressor genes, are hugely important in all cancers, not just melanoma. And if they're mutated or malfunctioning, you can get uncontrolled growth and cellular multiplication and formation of melanoma and other cancers. Okay, molecular pathways are important in forming a melanoma. Many molecular pathways are in melanocytes, and we're not going to go into details, but here's a couple of diagrams. This is a melanocyte, and this shows the pathways involved in growth and replication of melanoma cells and melanocytes. And this is all the work that's happened since 1970 when those first oncogenes were found. So that's 50 years of discovery. That's science, research. Here's a big one here, RAS, RAF, MEK, ERK. That's kind of a mantra with people in melanoma, RAS, RAF, MEK, ERK. That pathway, if you mutate BRAF here and turn it on, like I said, it's like pressing the gas pedal, you're gonna get this big green arrow proliferation, and so you're gonna get melanoma formed. And the people in this room, there's plenty of people in this room that you could ask them about any of these molecules and they could tell you about them. They could tell you about these pathways, and they know them very intimately. Some of the defects we see in different types of melanoma, familial forms of melanoma, CDKN2A gene, very charismatic name for a gene. This is a tumor suppressor gene, and that was one of the first ones that was identified as being important in familial melanoma. BRAF gene plays a role in 50% of melanomas. It's an oncogene. That's a huge thing in therapeutics for melanoma now. c-KIT, if you have a mutation in the c-KIT gene, you're more likely to get the acral, mucosal, and chronic sun damage melanomas. And for ocular melanoma, you might hear about this in the next lecture, BAP1, GNAC, GNA11, and a couple others make that more seen in ocular melanoma. So what have we talked about? Melanoma is a cancer mainly of the skin, but can arise in other tissues. Melanoma originates in melanocyte type of cells. They're an inherited and acquired risk factor for the development of melanoma. Sunlight exposure is an important risk factor leading to mutations in the development of melanoma. Oncogenes and tumor suppressor genes are important in the development and proliferation of melanoma cells. And more is being understood about these factors all the time. Improved understanding will lead to better prevention, detection, and treatment. Research is the key. All this has happened in the last 50 years, essentially, and it's just such a bright future for melanoma research. Anyway, that's what I have to say. Thank you very much.
Okay. Okay, great. Thank you, Dr. Linden. And so in your packet, there's a quiz. Don't look at it yet, but you'll have to fill out all those pathways with the names on them. But as Dr. Linden mentioned, they have, now that we've discovered some of those things, they are part of therapies that are in clinic. So it has been an amazing couple decades. However, we got more work to do now, and we're going to go from the outside to the inside. So come up, Dr. Scott. As Dr. Linden mentioned, melanocytes are in other places besides the skin, including the eye. And while it's not the most common presentation for melanoma, it does take some expertise. And we're lucky today to have Dr. Scott here to help us understand a little bit better this rare, but unfortunately sometimes deadly cancer. And there we go. Right. And I am gonna, where's my share? One day it'll be a little bit quicker. Okay, ready?
Perfect.
There you go.
Well, hello, everyone, and thanks for having me. My name is Nathan Scott. I'm an ocular oncologist and a vitreoretinal surgeon. And today we're going to talk a little bit about how ocular melanoma sort of presents in my clinics and sort of the conversations that I have with my patients. I have no financial disclosures. So again, this will be a little bit of an overview of ocular melanoma. I hope it's not too basic for everyone, but we'll talk about the clinical features, the treatment, some of the more important discussions that I have with patients, and then some of the resounding clinical questions that we ultimately have and hope to answer in the future. So as Dr. Linden sort of already mentioned, melanoma comes from melanocyte. A melanocyte is a pigment containing cells. The pigment is called melanin, and this is where melanoma tends to derive. The most important thing that happens in my clinic is pretty much just differentiating this from skin melanoma. It's very, very different than skin melanoma. Patients often ask me, I have a family member who has skin melanoma. Is this related? Should I talk to my other family members to see if they have things like this in their eye? And in all reality, they're very, very different. Those mutations that Dr. Linden was talking about are almost completely separate in terms of these entities. They also metastasize differently, which means we treat them differently. So they're essentially two different diseases is kind of what I tell people. Uveal melanoma is the most common intraocular malignancy in adults. We see about 1,700 to 2,000 of them in the US alone. So it's very, very rare compared to the skin melanoma. The uvea, which is why we call it uveal melanoma, is where these melanocytes derive and where ultimately melanoma comes from. The first structure in the eye that is, the uvea is three structures. The first structure is the iris, the second is the ciliary body, and the third is the choroid. So in terms of iris melanoma, about 5 to 8% of uveal melanomas arise from the iris. Only about 5% metastasize within 10 years. So this tends to have a better sort of risk profile. Some of the associated conditions are having fair skin, light iris color, numerous cutaneous or iris nevi, congenital ocular or oculodermal melanocytosis, uveal melanocytoma, and then my favorite, arc welding, because it's kind of neat and nobody really understands why this happens. It does present about a decade earlier than the posterior segment uveal melanoma, and we think that's most likely just because patients can see it when they look in the mirror, any changes in their iris. Most importantly, you notice that UV is not on this list. So there's actually no indication that sunlight actually increases your risk of developing uveal melanoma, which is another sort of just important thing that I talk to my patients about. I still do tell them that they should, wear sunglasses, have UV protection, but there's no indication that that's actually related to uveal melanoma. There are some studies that suggest maybe, but it's certainly not definitive. So when we evaluate an iris melanoma lesion, we're looking for elevation, vascularity, tumor shedding, satellite lesions, angle invasion. The angle is sort of the periphery of the iris where you get drainage. If you do have angle invasion, then you'll often have elevated intraocular pressure. That's the elevated IOP there. Sentinel vessels. Sentinel vessels are irregular vessels on the surface of the eye. And then extraocular extension. Sometimes you can actually see the tumor burrowing through the eye structures. And it's very important to differentiate these from iris nevi. So quite often, many people have iris nevi, and they will have many of those same features that iris melanoma tend to have. And quite often, we're just sort of monitoring them. So these are all benign lesions that have been watched and have not actually turned into melanoma. Management options include observation. typically not recommended. Sector iridectomy, iridocystectomy, these are just two surgical procedures where we actually excise the lesion and the surrounding tissue of just the lesion. So you'll end up with like a divot in your iris. External beam radiation or plaque radiotherapy. And then lastly, enucleation, which is removal of the eye as reserved for eyes that are either not going to do well or the tumor is just too big to undergo some of these other treatments. Here's an example of a plaque radiotherapy for an iris melanoma. You can see this is an amelanotic melanoma, so it doesn't have any pigment, but it still does come from melanocytes. And you can see the regression after the plaque radiotherapy. It regresses very nicely. This is another thing that I often have questions about in my clinic. People are always asking, why do I still have the lesion there? Why is there still a picture of it? And this is just quite often just fibrotic tissue that doesn't grow. We still watch it for signs of recurrence, but quite often there still is residual tissue. So moving on to the ciliary body. This accounts for 12% of all uveal melanoma. It has the same risk factors as the iris melanoma, but presents much later. It's often a very delayed diagnosis because, as you can see in this picture, it sits right behind the iris. So it's very hard to see. And quite often you can't even tell it's there until it's large enough to affect the vision. So these patients tend to not do as well as the folks with iris melanoma, just because it's sort of allowed to grow for much longer of a time. People develop a unilateral cataract or a cataract in one eye or an astigmatism. Sometimes you can just see those episcleral vessels, which we'll see in a moment, or just the extraocular extension. And here are two examples of that here. You can see sort of the very dilated vessels sort of sitting in only one quadrant. You see the rest of the eye is nice and white and quiet. And then here, obviously something's going on there where we've had the tumor start to invade through the eye. So now back to choroidal melanoma. This is the most common uveal melanoma that we see. The most concerning risk factors for growth, things that we're sort of constantly imaging these patients for, are thickness, orange pigment, reflectivity on our ultrasound, the diameter of the tumor, angiographic hotspots. This is when you get a fluorescein angiogram looking at the vasculature within the tumor, subretinal fluid, and then very importantly, symptoms. Patients can oftentimes develop flashes, floaters, or even just a little bit of blurry vision. Here are two examples of some patients that I saw in fellowship and why it's so important to get photography and to monitor these patients frequently. The top photo is a patient who was seen in a retina clinic, was told to follow up yearly for exams, and he was lost to follow up for about 7 years, and he returned with this Goomba that you see up on the top image there on the right. The bottom patient is another patient who was followed by a retina specialist, and quite frankly, they just didn't notice that it was slowly creeping, slowly growing towards the nerve, just because it kind of has the same appearance as it always did. And it wasn't until they developed the elevation that they noticed that they decided to send to our clinic in ocular oncology. But you can see that this was probably migrating towards the nerve for quite some time. So I always tell my patients to bear with me. I get photos every single time they come in, just so that we can even see the smallest differences in any tumor growth. So moving to the clinic, the most common scenarios that I have are either this one, where the clinical features are very consistent with melanoma. It's a bit of a slam dunk. We don't really have any questions about the diagnosis, and it moves on to treatment almost immediately. So the two main treatment options that are used in the US today are brachytherapy. That's this small gold disc here that we suture to the eye. It has radioactive seeds inside of it. There are different types of radioactive isotopes that people use. You typically suture it onto the eye. You leave it there for 3 to 7 days, and then you take it off. And this actually has a single surgery success rate, curing the it of greater than 96% at most centers. The second option would be proton beam therapy. It's used much less often, but it has similar success rates. So after we sort of talk about brachytherapy, I think the next biggest thing that we do nowadays that wasn't always done is we have to manage radiation retinopathy or radiation optic neuropathy. So about 15 years ago, quite often people would get radiation, and then about 1.5 to 2 years in, they would slowly start to lose vision, and there was nothing we could really do about it. We would say, well, the radiation kills the tumor, but it also damages the normal structures, including those important normal structures like the macula and the nerve. Nowadays, we treat these patients with anti-VEGF therapy, injections, or steroids directly into the eye. And many of us think that this helps preserve vision. There's never been a randomized control trial. There's one that's starting pretty soon to look to see if this is actually working in a randomized trial. But anecdotally, most of us tend to do this. So this becomes a very important concept for patients because, you know, when they're thinking about their treatment and depending on what their vision is at the time, you know, they're subjecting themselves to, you know, every 2 months, every 4 months, or even monthly injections of coming in to get an injection into their eye, which can be kind of tough. And then we talk about biopsy. Biopsy is really important, not so much for a diagnosis. This is largely a clinical diagnosis. We sort of know it when we see it, all of those clinical features. Sometimes you get intermediate lesions that you're not sure, but big picture is we take a piece of the tissue, not so much to make the diagnosis, but to send for gene expression profiling to give our patients an idea of what their likelihood of having metastasis in the future really is. This is not a non-invasive procedure, as you can see here. It basically, we have to put a needle completely through the wall of the eye, through the chamber, and even through the retina and in the tumor, just to get a small amount of tissue for these biopsies. So it goes without saying that this does not come without risks, although the complications are very, very low. Here is actually a video of a different type of biopsy that we do when the tumor is a little bit more anterior, you know, accessible right through the eye wall. So I would say shield your eyes if you don't like to see blood or eye videos, but this is sort of just an example of what we get to do in the OR for some of these tumors to get tissue. And this is one where we had a little bit of trouble getting a good sample. But as you can see, we just sort of pull back the conjunctiva to expose the area. We do a little bit of cautery so that we don't get bleeding. This is how we see where the tumor is. We're shining a light through the pupil, and you can see the shadow right there. And we outline the shadow to, you know, localize where the tumor belly is. And then this approach, sometimes we'll just put the needle right through the eye wall, but this approach here is to try to reduce any risk of seeding, any tumor cells getting out from inside of the eye and, you know, adhering to the, underneath the conjunctiva around the sclera. Here you can see we just put a needle in, we aspirate, and we take a few cells. This one we had to do a few times because the cells that we were getting were not very adequate. So we ultimately end up, you know, just trying to grab a little piece of tissue and cutting it out to send to our pathologist. And then for our patients who are, and then we do a little bit of cryotherapy to make sure that there's no tumor seeding as well. But for our patients who have already had this done, you'll see, you know, right at the end, you remember after your surgery, how you were feeling itchy and scratchy for the next 4 to 6 weeks. That's because you have small little sutures that do absorb on their own, but they're sitting right on the surface of your eye. So every time you blink, you know, you feel those. So that is an indication for that. So that biopsy there, we send off to a lab for gene expression profiling. You know, this is probably one of the biggest things that's happened in uveal melanoma over the past, 15 years or so, is this gene expression profiling, which takes a 15 gene prognostic profile and basically places patients into risk categories. The first rendition of this puts you in a class 1 being a low risk and class 2 being a high risk. There was further analysis that made this third rendition that everyone's probably familiar with, where you get a class 1A tumor, class 1B versus class 2. And I will often, sort of bring something like this up in the clinic for my patients while they're there, just because they're often being followed for these lesions in their eye. And they're saying, I've had this for 6 years and now all of a sudden it's growing. Why is it growing now? And it wasn't growing before. And we talk about this pathway, which is fairly well understood, that you have choroidal melanocyte. You have a primary driver mutation in the G protein. Dr. Linden mentioned the GNAC and the GNA11 mutations. This likely turns into an early choroidal melanocytic tumor that has the capacity to grow. And the large majority of these probably just turn into these dormant nevi that we're all watching and that aren't growing. There's an arrest of growth that's likely either related to mutations or the immune system sort of suppressing it. It's not until you get a secondary driver mutation, one of these, the most concerning one being BAP1, that you actually develop with a malignant tumor that becomes concerning. And I'll usually pull up these results for them. This is what the Castle Biosciences sheet gives you once you send one of these in. We talk about how a class 1A has a 98% chance of being metastasis free at 3 and 5 years. And then, if you're unfortunately in that class 2 bucket, it's about a 50% chance of metastasis at 3 years and a 72% chance of metastasis at 5 years, which can be quite devastating for patients. So I'll usually point them to some more recent work that has been done since those results, where they've shown that we probably overestimate these numbers. And in real life, these are studies from Iowa and I believe it was Case Western or Cleveland Clinic that showed that those class 2 tumors probably don't metastasize quite as often as those results predict, but it's still much higher than the class 1. PRAME expression is something that you also get in your results. We don't, it's not validated yet in terms of a true marker, but many of us in the community do believe that this is sort of a modifier of risk. It's likely that PRAME expression makes you much higher, a higher risk of metastasis. So those patients that do have like a class 1 tumor and they're PRAME positive, we are a little bit more concerned about those, and we'll tend to screen them more often. The second patient clinical scenario that I get is when you have some of the features that are consistent with the melanoma, but not all of them. And these can be really, really tough and challenging because patients, they're worried, they're concerned, and we are as well, but we don't want to run into a scenario like this where we're treating things that otherwise wouldn't have been a problem. Think back to those injections that I talked about. If you're treating a nevus and now a patient is getting these injections to prevent radiation retinopathy, every 2 months or every month, that's a pretty big burden for those patients. So this is just a clinical report that I found where they had a patient, he was 47 years old. They had a 4x3 millimeter choroidal nevus at presentation. You see that here on the top. And then over the next 4 years, it had elevation, it had orange pigment, subretinal fluid. The patient endorsed flashing lights. So it was pretty much nailing all of the things, a lot of the things that we're concerned about in this being a real melanoma. They did not want to deal with injections. They did not want to deal with having this in their eye. So they underwent an enucleation, and it ultimately ended up being a benign nevus on pathology. So this is the type of thing that we're trying to avoid. So does growth equal melanoma? Oftentimes, this is the biggest question that I get when I tell patients that I want to watch and wait. I don't want to treat them with radiation therapy if it's not definitively a melanoma. So I often point them to this quote by David Abramson. He's a prominent ocular oncologist in New York, and he mainly sees kids, but he basically says after 13,000 examinations, he's only seen one child with a choroidal nevus. And what this means, because we know that choroidal nevi are in about maybe 6 to 10% of the population, that all nevi grow because at one point you didn't have it and now you do. And at one point it was small and at one point it's much larger, but that doesn't necessarily mean that it's a melanoma because all nevi grow. So here's a interesting study that was done more recently where they basically said that class 2 was a definitive malignant melanoma. And that was going to be sort of their true positive. And they looked at all of the clinical features of these class 2 positive melanomas: subretinal fluid, symptoms, orange pigment, less than 3 millimeters distance to the disc, drusen, and low internal reflectivity on that ultrasound, that B scan, as well as age and gender. And basically they found that the only things that were significant risk factors were age and thickness. Documented growth wasn't even associated with being a class 2 tumor, which is interesting because these are all of the things that we use in clinic to determine whether or not we're going to treat patients, whether or not we're going to say this is a clinically diagnosable uveal melanoma. But in summary, a lot of the literature is showing us that growth is not equivalent to malignant transformation. Now, the classic clinical features that we just talked about are pathognomonic for malignant transformation, and observation is always reasonable, even if you're a little bit concerned that it may just be a nevus that has arrested. So questions from the clinician. These are things that I think about all the time. How best to differentiate choroidal nevi from small melanoma. We still have work to do. At some point, we're going to have better blood testing so that we don't have to put a needle through the eye, or even anterior chamber fluid, which is an office test. We wouldn't even have to go to the OR. Better prognostic markers. There's issues with the GEP class and the PRAME. There's always this question of, how much should size really be informing us? And then treatment of high-risk disease. There's now some neoadjuvant trials that are undergoing to treat high-risk disease, but, there's certainly more that needs to be done. And then treatments that don't involve radiation. It'd be very nice to not have to inject patients with this medication, every month or every 4 months or so. Treatment of metastatic disease. Hopefully we get to talk about that a little bit more later. As we know, tebentafusp was probably the biggest thing that has happened in metastatic uveal melanoma over the past century or so. And then clinical trials, we're starting a few here, and I'm happy to sort of talk about those as well later. So thank you to my mentors, and here are my citations. Questions?
Thank you very much, Nathan. And it takes a special person to do those type of things, and we're really lucky to have you here leading that group and doing some of these clinical trials. Dr. Chmielowski. Okay, so Bartosz Chmielowski from UCLA is our next speaker up, and we've known each other for a little while, but really happy and excited to have him here to talk about some of the newer things that are back in skin melanoma in dealing with patients who have a high risk of it coming back, and ways we can lower that risk. So with that, hopefully you see those slides, and perfecto.
Right. Okay, thank you for inviting me here. In the next, hopefully 20 minutes, I'll tell you a little bit of the therapies we are trying to use to prevent recurrence of melanoma after surgery. And of course, there is a humongous progress in treatment of metastatic disease, but in the last few years, we've been doing also quite a lot of progress on moving these therapies earlier to offer for the patients who are at risk for recurrence after surgery. So how do we manage surgically? So this is a very brief summary. So of course, these are the patients from my clinic. You already saw in the first presentation several different melanoma lesions on the skin. As you can see, they may have a different appearance, different flavors, but you go to your dermatologist, undergo biopsy, and you receive a diagnosis of melanoma. When we think about the prognosis and staging of melanoma, we look at several features. We look, how deep it goes into the skin? Does it have something what we call ulceration? Did it travel to the local lymph nodes? And of course, did it travel to other parts of the body? Based on this, we get the stage of melanoma. And if it's only on the skin without lymph node involvement, you have a localized disease. If there's lymph node involvement, still there are surgical options. If it travel to other parts of the body, surgery would have a limited function in this case because it's already in other parts of your body. So traditionally in these patients, as you saw, you see the primary lesion, your biopsy showed it's melanoma. You go to a surgeon, they inject, when they plan for surgery, they inject a dye to find the closest lymph node. So we assume when we know that melanoma likes to travel to the lymph node. So if you inject the dye will choose the same pathway melanoma would choose to travel to the lymph node. And this is radioactive dye, so it can be detected, and this is what we call our sentinel lymph node. So when the surgeon does the surgery, they do undergo white excision and then sentinel lymph node biopsy to assess the closest lymph node. If you already have enlarged lymph nodes, or if your sentinel lymph node was positive, in the past, in VP, everybody who has positive sentinel lymph node, they were removed. Other lymph nodes from the same area were removed. Today, we don't do it so often, but if you have multiple positive lymph nodes already on your exam or so, then still, it remains a standard of care. We are trying to change it, but still to remove all the lymph nodes from this area. And this is something what we call lymph node dissection. I told you already about stages. Stage 1 and stage 2 is only localized disease. Stage 3 is the one that travel to the local lymph nodes, for simplicity. Stage 4 is the one that travel to other parts of the body. On the right side, you see the stage 1 patients and stage 2 patients. On the left side, you will see stage 3 patients. And one thing which I wanted to point out, although you might have a lower stage, let's say here the green curve shows stage 2B, and the higher on the curve you are, the better your outcome. So this is how many people survive depending on the stage. So if you have stage 2B, the 10-year survival is 82, but actually this is actually worse survival when you had as patients with stage 3A, which a 10-year survival is 88. If you had stage 2C disease, then your survival is very similar to patients with stage 3B disease. So it shows the weakness of our staging system, but not always lower stage means that you have a better prognosis, but also it indicates for us when we need therapies, not only for stage 3 patients, so the ones who have spread over disease already to the lymph nodes, but maybe even to patients who have just the skin lesions, depending on your stage. I'm not going to go into details of that, but so when we think about principles of the therapy, I think it's extremely important for the patients and for us to understand the principles of the therapy. This slide is probably right now 15 years old or 20 years old, but it still holds. We can have two methods of the therapy. We can target the tumor, and this is what traditional chemotherapy is doing in multiple cancer. We don't use chemotherapy so often, but we do look for these mutations which I mentioned. So we can target the particular mutations in melanoma and use it in what we call it a target therapy. But we can also use the immune system, and then the immune system is not necessarily part of the tumor. It's our natural defense mechanism against bacteria, viruses, or organs, but we can use the same immune system, and then this is indirect fighting of cancer. So in immunotherapy, immune system is very good, not only because it's quite specific against, specific mutations or antigens which we can find in bacteria, viruses, but also in the tumor. It can be adjusted and it has a memory. So it's a good mechanism to fight cancer. And where we have our immune system is has a very broad specificity. Generally, we have two important group of cells, such as T cells and B cells that produce antibodies. That's why our immune system can protect us so well from all the viruses and bacteria which are all around us, because we have so many different specificities, and we can adjust. Once the antigen is identified, then the cells proliferate and get rid of bacteria. Why is it not so easy to use the immunotherapy? We've made humongous progress in patients as a part of treatment of cancer. So some patients when come to my office say, what can I do to boost my immune system? Because we always talk about immunotherapy, how we are going to use it. And I often am disappointing them, because their immune system works perfectly well. If it wouldn't be working, they would be getting infections all the time. So it's not a failure of immune system. It is that your cancer outsmarted your perfectly working immune system. So this is one of the things. The second thing, our immune system generally is designed to get rid of foreign. So if bacteria or viruses, which don't belong to our body, we get rid of it. But cancer comes generally from our own cells, or not generally, it comes from our own cells. So although cancer is abnormal, resembles your own normal cells very much, and our immune system is designed not to get rid of self. So this is what Luckily, they are not identical. We are depending on these differences between abnormal and normal cells, but this also makes it difficult for our immune system to use immune system to fight cancer. We already talked about mutations in melanoma, but what I just wanted to say is where people were looking at multiple melanomas, the most common mutations are in the protein called BRAF, and the most common is V600E mutation. Then the second group would be NRAS and F1, and then there are some other mutations which can happen in melanoma. I don't want you to fully understand this. I just want to show that about 40% of melanomas contain mutation in the protein called BRAF. So I already showed you if you undergo surgery, the patients are at risk. Then although the surgery went completely well, the surgeon comes out and says, I got it all. But go and talk to an oncologist and see what he's gonna say. And when you come to an oncologist and the oncologist disappoints you, yes, the surgeon got it all, but you have 50% chance then there is something else hiding in the body, or 20%, or whatever, depending on the features we discuss. So now you are coming and say, can I make a difference and improve these chances? So right now we have several therapies approved. There are actually more approved, but these are the ones which are in use. So either the immunotherapy drugs, which are what we call PD-1 blocking antibody, pembrolizumab or nivolumab, or if your melanoma had BRAF mutation, then you have another option, which is a targeted therapy. And right now, the combination of dabrafenib and trametinib is approved in this population. All therapies are given for 1 year. Surgery is a prevention of recurrence. So you are followed with physical exam and imaging study while you're on the therapy, and you finish the therapy and you are still followed to be sure when the disease did not come back. I don't want you to fully understand these curves, but it shows that upper curve means you did better. Lower curve means there is a high chance for recurrence. And I showed you several very similar curves showing that pembrolizumab for stage 2 melanoma, there is a difference between people who received pembrolizumab and people who did not receive pembrolizumab. I just want you to remember, then the brown curve says they did not get it, so they were treated only with surgery. So it does not, I'm not saying that surgery is a bad thing. As you see, majority of patients still got cured with surgery, but unfortunately many did not, and we are trying to improve it. So this is what makes the therapy after surgery difficult, because that you talk to one patient, but if you that you look at the whole group of patients, some are already cured, but you will be giving them therapy. And you don't know who it is. So you're giving the therapy, they're at risk for side effects. You have to treat everybody, but that you benefit only % of it. Similar results for nivolumab. We are not going to go detail into numbers. I think this is for stage 3. For stage 3, these drugs were approved first, so we have a longer follow-up. But again, this is a pembrolizumab curve, and this was a placebo curve, so there was a differentiation between these two. This is for nivolumab. Nivolumab was actually compared to other drug, which we also use right now mainly for metastatic disease, called ipilimumab. The difference is smaller just because they did not use placebo as a control arm. But in targeted therapy, we have very similar curves, and I'm not going to go, as I say, we are not going in details into numbers, but you see the targeted therapy has also good separation between people who receive targeted therapy, dabrafenib, trametinib, or placebo. A lot of patients ask about this trial. So as we know, COVID vaccine was a huge success in prevention of severe COVID and prevention of infection. But actually, with RNA vaccines were initially developed for cancer, just the development had kind of slowed down because the COVID infection came and was easy, and this actually expedited the development of these RNA vaccines. So Moderna came up with this vaccine. So what if we take the tumor and try to find the antigens or the antigens which are different and create the vaccine and use it in combination with pembrolizumab? It's a little bit more difficult than with COVID vaccine because COVID, we know the structure of the virus, so we can make it can be on the shelf. Here, every melanoma is different, so you have to have a sample from the patient and create for each patient a separate vaccine. In our early trial, we see quite a nice separation, so improvement. This one, the bottom curve shows right now pembrolizumab alone, but now pembrolizumab plus vaccine. The confirmatory trial showing when this is real is ongoing, and we'll see, if we can improve over what we have already right now. The reason I talk to you, when it's so important to think about the therapy, why not to give everybody? Yes, we would like to give it to everybody, but we have to remember when they can come with significant side effects, and I'm not gonna go into details, but and the side effects sometimes are life-threatening, and 1 per 100 people can die because of adverse events, or they can be permanent after the therapy. So you have to really think what's your acceptance of risk and what are the chances that your disease will come back after surgery. Because if you have stage 1 disease and you have maybe 1 or 2 or 3% chance of recurrence, somebody will recur, but it means that 97% of people will be treated for no reason. And on top of that, about all people will be at risk for side effects. So this discussion is extremely important when you make decisions to treat or not to treat. Now, now we say, can we do even better? So what if it's a little bit different patient population, but what we already know when the lymph node is involved by cancer. Sometimes we don't know, only the surgery shows us, but what if a patient comes with already swollen lymph nodes, or you did your scan and the lymph nodes are enlarged? Can we do something, maybe we should start therapy before the surgery rather than after surgery. And it's assumption that maybe immunotherapy will be working better. Let me explain to you. We know that the immune cells are attracted to cancer, attracted to tumor. So if they are attracted, very often they sit in this tumor. So if you undergo the surgery, majority of the cells which are supposed to be fighting, your immune cells fighting the tumor, are removed with the surgery. So we know that there is a risk that there is some residual tumor left behind. So you know that not all the cells are removed. But they say, but you are actually removing the fighters with the surgery, and now you are coming with immunotherapy afterwards, hoping that you are going to stimulate the fighters. But many of them were already removed during the surgical procedure. So what if we try to activate the cells before surgery? So they are already active, then you undergo surgery, but you already have activated cells in your body that can continue fighting possible residual cancer. So that's why with SWOG, Southwestern Oncology Group, you run this clinical trial. Everybody got the same therapy, 18 doses of pembrolizumab and surgery. But half of the people got just 3 doses before surgery and then went to surgery and then finished their pembrolizumab. Half of the people got surgery first and they got pembrolizumab. I have to say, I had patients who had anxiety about it. They say, oh my God, you are gonna leave my tumor in the body, allow it to grow while I'm getting therapy, and I'm not gonna have surgery immediately. But what we actually saw, when there's a 20% difference if you got your therapy before surgery. So now if this is the first time when we see an evidence, when it's not only important what you get, but the sequence and when you get it. It's not every patient with melanoma, I repeat, because you have to have evidence of involvement of lymph nodes before the surgery is done. Because if you learned that when lymph node was positive after surgery was done, then of course it's already done. But if a patient then right now we say, don't go immediately to surgery. I know it's stressful because your tumor stays in the body and the doctor tells you it's going to be another 2 months in the body before you undergo surgery. But you're going to do so much better if you get the therapy before. So we are trying to make it even better. What if we do nivolumab, ipilimumab? So combination, just 2 doses of treatment. And I'm not going to the details of this, but it clearly shows that more than 60% had, when they went after the 2 doses of combination treatment, more than 60% of patients had no melanoma left in the lymph node. And these patients, as you see, almost no one developed spread of the disease, and very few patients recurred. If there was residual melanoma, and they did not undergo any other treatment, so they underwent the 2 cycles of immunotherapy and removal of the positive lymph node, and then the majority of people did not have melanoma in this lymph node. But if there are other patients who had residual melanoma, they do not do so well. It means when they do need some additional therapy, the 2 cycles might not be sufficient. So this is something to think as, can we minimize the surgery? Can we shorten the therapy? So these are the future questions for which we have. So can we, right now it remains, if you have enlarged lymph nodes, it remains a standard when if your surgery will remove all the lymph nodes from this area. But if we use the successful therapies, can we omit it and remove only the lymph nodes that are enlarged, but leave the rest behind? There will be lower risk of swelling of the arm or the leg. There is a lower risk of infection. So then again, what we see, how do we gonna differentiate? You remove the lymph nodes. You already know that people who, if you cannot see any viable melanoma, these patients are gonna do well. What about the ones who have some? What's the right? Should we change the therapy after that, or should we continue the same therapy for profound? So these are the questions we'll be asked, where we are trying to answer. Will be the time when we can eliminate surgery completely. Surgery will be still an important method of treatment for melanoma, for different, but we will hopefully find a different function for surgery or different time for surgery. So it's not like when there will be complete elimination. And again, we already talked about when you make your decisions, you cannot forget about side effects, because some side effects can be life-threatening. Some side effects will persist for the rest of your life. But of course, if your risk of coming back of a disease is very high, I think this risks, it's worth taking this risk because melanoma can take your life. But if your risk of coming back of a disease is low, you really have to think, is it worth, getting the therapy and taking the chances of side effects? All right, that's all. I think it was a sprint presentation, but hopefully gave you a general impression.
Okay. Don't go too far. Thank you. We're going to have a little bit of time for some quick questions and answers, and Sam's bringing up her computer to help. So we need the 3 speakers back, and got some microphones here. And if people in the audience have questions, they can write them down and bring them up. And move the camera, Daniels. Go ahead. Okay. Oh, perfect. I might be up here because then I can look at your screen. Okay, so a few questions and then we'll get on to the break and then regroup, but okay, sure. So I'm reading from the chat on the Q&A. Are all melanoma survivors at high risk of developing pancreatic cancer? And is there anything that can be done to reduce the risk? So sometimes I'll rephrase that question a little bit. Sometimes, melanomas cluster with other cancers, and depending on familial risk genes, there can be some connections between them. But maybe I'll have Dr. Hemilowski comment on that kind of situation.
Yes, so actually, yes, there are some genetic predispositions that can give a predisposition to melanoma and pancreatic cancer. We see that actually familial melanoma or the melanoma dependent on the gene mutation in your germline is actually extremely uncommon event. So majority of melanomas are not related with the genes which are passed by a particular gene which is passed from your parents to you. So generally speaking, the risk of pancreatic cancer in patients with melanoma is very low. But if you have features, when you had multiple members of a family with melanoma, it's worth testing yourself for germline mutation. Your doctor can order that, and then if a particular genes are found, then they can put you at risk for pancreatic cancer. So there is a relationship between these genes, but it's extremely uncommon melanoma, probably 1% of melanomas or so.
Okay, thank you. I'm going to combine a couple questions for Dr. Linden. So can a pathologist report tell me if the melanoma came from the sun or if there's some other thing in the environment that made it happen? And kind of related, I think, if people with melanoma are at higher risk of all forms of skin cancer.
So when you look at a pathology report, you cannot tell whether the melanoma originated from sun-caused mutations or other mutations. We're not at that level yet. There are certain signatures that are more favored with sun-caused melanomas, but you don't see that in a pathology report. That's at the molecular level. So maybe in the future, when we look at the actual molecular changes in the melanoma, and we're doing that now and more, then maybe we'll be able to say this is more likely to be caused by the sun, or this is more likely to be caused by X. But no, you cannot tell from a pathology report where the melanoma came from. What was the other question?
So does it mark you at risk for other skin cancers?
Yes. Well, if you have melanoma, you are at increased risk of developing other skin cancers for many reasons. For one thing, people who are at most risk for melanoma are the people who are more fair-skinned. If you have red hair, that means you kind of have a different type of pigment, melanin. It's called pheomelanin. And people with pheomelanin, they have fair skin, freckles. They're at increased risk for melanoma and other skin cancers because of the set of genes they've inherited, which make them just at increased risk for skin cancer because they're also more sun sensitive. Their skin is not blocking the sun as well as people of, for instance, Mediterranean or darker skin types, where the darker your skin type is, the more built-in sun protection factor you have. And so we know that people who are more like a form melanoma are more fair skinned.
Great.
May I kind of add a comment, rephrase Dr. Linden in his presentation told us, so many patients grew up here in Southern California on the beach. So that's true. You had a significant sun exposure. Not everybody develops melanoma because there are protective factors in the skin. But yes, UV exposure increases your risk of melanoma. Avoid significant sun exposure. Sometimes I tell my patients, you will pay when you are older for that. Your skin will remember every single day on the beach. You will look old. Like in Hollywood, sometimes it makes a better difference. Say your skin will look old and you will have squamous and basal. I'm trying to make it a little bit funny and all of this, but it is true. Your skin will remember sun exposure. It doesn't mean you have to sit in a dark room right now and not, but use protection, avoid tanning. This is the aim, banning on tanning for people under 18. This was one part of the foundation efforts. It's not excessive sunlight is not good for you at all. So try to avoid it. It does not mean that everybody will develop, but it's not good.
Okay, thank you. Couple questions for Dr. Scott. So if ocular melanoma comes back after the eye has been removed and it comes back in organs, what treatments are done?
So there typically are no treatments done by the ocular oncologist. This will usually move to our medical oncology colleagues, but there are various local treatments, radiotherapy, ablation, and more recently, there have been a lot of systemic medications that are being attempted, including MEK inhibitors, including some of the immunotherapies that we've talked about for skin melanoma, and then the most common, well, maybe not the most common use, but the one that people are most excited about right now is Dept, which is a new novel medication as well.
And if you don't mind commenting on clinical trials, for example, some of the stuff you're doing.
Yeah, so we're entering clinical trials with the company IDEA, where it's darovasertib is a PKC inhibitor. It's a pill. There are two different trials associated with this medication. One is a neoadjuvant. This is the one that I'm pretty excited about. This is for patients who would otherwise undergo an enucleation. These are tumors that are too large to treat with radiotherapy or are causing other complications where we think removing the eye is probably better. They have some preclinical data that suggests that maybe this drug, darovasertib, shrinks the tumors to a size that you can now irradiate the tumor and not be concerned about some of those complications that you get with radiation. There's also an adjuvant trial where they're combining darovasertib with crizotinib for patients with high-risk disease. These are the patients with class 2 tumors, BAP1 mutations, and we're excited to be starting those pretty soon.
And Dr. Hemilowski, I know you have some experience in some of these medications you might want to share.
Yeah, no, I'm the main uveal melanoma doctor at UCLA. So in my practice, I have about 150 uveal melanoma patients right now. And so we've been a part of the bentafusp development. It is an exciting drug. Just the general thing is we are using immunotherapies, which we use for cutaneous melanoma, it was mentioned. The outcome of patients with uveal melanoma is not as good as patients with cutaneous melanoma. We've made progress. So people say, oh, you know, your responses to immunotherapy might be only so many percent, means it doesn't work. No, it still works. It can make you live longer, but these are not the magnitude of responses we see in cutaneous melanoma. But we've made a lot of progress. I mean, I do have patients who develop metastases and alive 5 to 10 years after that. The specificity of uveal melanoma is when very often the metastases are only in the liver for a long time. So this makes when liver-directed therapy an important part of the management of this disease. So you have to have a good friend, a good interventional radiologist who can treat the lesions in the liver and preserve the liver function, and this will give you a longer life. We ran with a phase 1 clinical trial of darovasertib and crizotinib. So we at UCLA, we treated, I think, 30 patients with uveal melanoma. It's a first targeted therapy when we had profound responses in these patients. And right now I have patients who've been on this for about 2 years. But I have to say, not everybody benefits. Some benefits are shorter, but some people have a persistent benefit. So now we are, for metastatic disease, we're running a randomized trial. We'll see if it's going to be better than whatever standard therapy we have. So there is excitement, there is a progress. We are just about to start, our isolated liver perfusion with melphalan, where if you have only liver metastasis, we are going to separate, the liver is blocked for a short time. You infuse chemotherapy just into the liver to treat the whole organ. Then you filter it out and you release it. And it's a one-time procedure, but you can repeat several times if needed, to control disease in the liver. So I think it's a much less common disease. We are only about 2,000 cases a year in the whole country. But there are strong support groups, and although we would like the progress to go faster, we are making a progress. There was very exciting data presented in November of a specific. You might have heard when there are specific mutations in uveal melanoma in the protein called GNAQ or GNA11. So there are GNAQ inhibitors that were available before, but were associated with significant side effects. Mainly the platelet count was going extremely low. Now Novartis came up with antibody drug delivery when they can deliver this inhibitor just to cancer cells, and the rest of the cells are much less exposed. And the phase 1 trial, which was run mainly in Australia, showed enormous response. So we'll see where it goes, but there will be progress.
Sounds exciting. If there are questions from the audience, just raise your hand and we'll get those sheets. So back to skin. So Dr. Linden, question is, do all melanomas spread? Does stage 1A spread?
No, that's the really good news, is that all melanomas don't spread. Matter of fact, the vast majority of melanomas don't spread because we're catching them earlier and earlier. That's one of the good aspects of education. Things like AIM that educate the public about melanoma, self-skin exams, what to look for. The earlier we can catch a melanoma, as Dr. Daniels, I think, said at the very beginning, that's your best chance of surviving melanoma. Stage 1A has a very low chance of spreading to other parts of the body, but not zero, interestingly enough. It's less than 5% chance of spreading to other parts of the body. It depends on a lot of different factors. But so stage 1A, we usually consider to be highly likely to be a success story. Stage 0, which is melanoma in situ. If it's true melanoma in situ, it shouldn't be able to spread to other parts of the body. We consider that to be a true success story if you catch it and get it at that stage.
This might be for Dr. Himilowski. So online, stage 4 melanoma to the lungs, received therapy after surgery, developed pneumonitis, one of those possible side effects from immune therapy, removed from treatment, but cancer-free for 2 years. Is it possible if I need to, can I get back on immune therapy?
So of course, this is a very specific situation. It's a complicated question because we don't know the full scenario. As I said, there might be persistent side effects. We have to see, first of all, for this particular patient, if you had metastatic disease and for 2 years you did not have disease back after your therapy, your chances that it will be back are very low, so, and by very low, I would say probably less than 10% or so, so the good thing is this patient is probably okay, may not never need therapy. I don't want to overpromise because occasionally I tell it to my patients and the next scan shows the disease came back. So sometimes I'm wrong, but luckily most of the time we are right. When with patients, they will not probably need additional therapy. If a disease comes back, then you have to reassess how bad was this pneumonitis. Was it the pneumonitis when you needed high-dose steroids, you were in the hospital on oxygen and all of this? Then probably not. If it was only that somebody found on a CT scan and they say, oh, you have some infiltrates, maybe we should take a break. So the severity of the symptoms will be very important, and it is with all the side effects. Then you might re-expose the people. Then you have to think, what immunotherapy did you use? If you used, let's say, PD-1 blocking antibody, you could use CTLA-4 blocking antibody. So there could be a change. Yesterday, our cellular therapy was approved, with adoptive cell transfer therapy. So if you use PD-1 blocking antibody, you had side effects, maybe you can go on TILs if needed. And this is a very different therapy. So the fact that you had side effects with previous immunotherapy will not predict for any side effects with let's say TIL therapy. So this is what's exciting also, that people who had really terrible side effects are at risk for recurrence, but they need therapy. At least we start getting immunotherapies of different mechanisms. We'll be excited. We are doing injectable clinical trials. We are starting right now, finally, a randomized trial. A new drug that will be injected into the tumors to stimulate the immune system. Again, this will be the drug. Then if you had side effects on previous therapy, you can still receive this one. It's because it's a very different form of immunotherapy. So yeah, the answer is possibly, but you need to know the details.
Right. Yeah. So there are a lot of questions about trying to predict treatment response and outcomes and stuff. So I'm going to do one for Himilowski, one for Dr. Linden. So one of the questions from the audience, what type of testing could be done to identify patients up front on the tumors to help predict response to neoadjuvant? And why would just 2 cycles prior to surgery? Why not 3, 4, 5, 6, 7? Why not keep going? Why not just get rid of surgery? That's where this. So you can comment on that. And then Dr. Linden, get you thinking about if you do have a melanoma, are there other, say, molecular type assays that you would consider to help stratify patients on their risk? So we'll do that one second.
Yeah, so these are important, very important questions, sensitive questions which we ask ourselves. So why 2 cycles? So first of all, if you introduce a new therapy, you know, as I mentioned, you know that surgery will cure a percentage of people. Before we had any of these immunotherapies, people were undergoing surgery. Yes, the risk of recurrence was high, let's say 50%, so 40% or some depending, But then you can look, but there was also 50% that never came back, or 40% or 60% that never came back. So a percentage of people, a significant percentage of people are cured with surgery. So when you introduce a new therapy, you ask yourself a question. You say, what if my therapy is not going to work? Then I'm delaying the surgery. So we thought in the initial development, when we do 3 cycles, let's say, of pembrolizumab, which is actually, if you start on 1 day, 3 weeks later, you get a dose, 3 weeks later, you are delaying the surgery maybe by 2 months. So what it means then for people who did not benefit from pembrolizumab, the delay in surgery is not so significant. They can go to possibly curative therapy. So when you develop, you don't want to put the patients at such a high risk. I say, okay, if I'm going to tell the patient, I'm going to do a year of pembrolizumab and then I'll do your surgery. What if they are not benefiting from the drug? And then this year of delay, you might lose the chance. Dr. Warren Chow is thinking about the clinical trial, then let's say let's reassess the patient and if they had a good response, you assess when they had a good response. So this patient will continue on the therapy. If you see it's not responding, we'll go to surgery. So this will be kind of an adjusted approach. Then if you don't, then not upfront. If you had a response, you continue. If you don't, then you go to surgery. So yes, there are attempts, but initially that's why we say, okay, let's do some, see what's the function, but not to delay surgery for too long. And how do we predict response to the therapy? We are not very good at it. I mean, period. There are some, the problem is, why do we say, some people look at the tumor mutational burden or PD-L1 expression. Yes, the higher PD-L1 expression, the higher the chances. But it doesn't mean that if you have lower, you are not going to respond. So unless we get a test that can clearly show us this is responder, this is not responder, getting the test, you are higher chance for response or lower chance for response is not very helpful, because even lower chance is still a chance for response.
Okay, and Dr. Linden, any molecular tests that you think are used earlier in identifying patients?
Yes, there are tests. If you have a melanoma on the skin, and you can cut that out, and then you can do molecular testing on it to try and see if there's a profile that makes that a lower risk melanoma, a higher risk melanoma. That's not standard of care. It's not used by that regularly, I would say, across the country. Castle Biosciences is the best known test in that regard. It's used most commonly, and it's commonly used if you're kind of on the border of like stage 1A, stage 1B. Do I get a lymph node biopsy, which has its own risks of surgery and also chronic lymphedema just from a sentinel node biopsy. Okay, once, let's say, a little bit higher stage, like stage 2, what's the risk here as far as determining whether we should go on adjuvant, neoadjuvant therapy and so forth. So kind of when you're kind of at the border stages where it's most commonly used, I think as the tests become more refined, they'll become more and more used. Like say, you can argue the science. I've been at many meetings where one person will get up and say, Castle Biosciences, it's a great test. The others will another person will get up and say, well, this is the reasons why it's not that useful of a test. And so it can be very frustrating because you hear one argument and say, let's use Castle Biosciences. You hear the other argument, it's not that useful, it doesn't sound like. So it's kind of interesting.
It's actually, it's interesting because we have to think, these are the companies when they use marketing to sell the products too. So what, sometimes they go, let's say, let me go to an ophthalmologist or let me go to a dermatologist and make them order the test. Then they get the result. oh, now you go to medical oncologist to interpret the result. I said, you ordered the results, you take no. So this is what, but sometimes was this company, and I'm not saying this is for joke again, but it is, you don't want to order the test when you cannot do very much with this test, it's not gonna change your practice. Or at least if you order, you have to be aware of that, is this test going to change what I do? Do I have enough evidence to change what I have practice? So this is something what physicians we have to think and explain also to the patients, For the longest time, I have to say I was against castle testing in uveal melanoma because the only thing what I could do for this patient is say, yeah, I can scare you more or less. This is the result. This is the benefit from getting the test. We are adjusting maybe the follow surveillance after the cancer, but people, even with class 1A on the paper, they have wonderful prognosis. And I'm telling them you have such a good chance when it's not going to come back. They still want to get their scans. So this test kind of did not help them. And people with class 2, I'm scaring them. You have a very high risk that disease is going to come back. We'll continue doing scans as we were doing or as we planned before. So, but the treatments are coming, like darvosertib in the adjuvant, all of this. So this information will be crucial. So I don't want to say the prognosis is important, but the tests that can help you not only to tell you, okay, you have a bad disease or you have worse disease. It's more important if you can intervene based on this information. If you don't have successful therapies to intervene, well, maybe you should not order the test. But we'll see. It's a progress. I'm not completely critical, but I just wanted to share my thoughts.
Great.
I'll just chime in there as well. It was really, really tough to order the Castle Biosciences test and not have interventions. The only thing you could tell people is we'll screen you more, or maybe you'll be eligible for a clinical trial. And I probably contribute to your burden, I have to admit, in that even when I get a class 1A patient, I have to tell them that it's not infrequent. It's rare, but it's not all that infrequent. Everybody has them where you have a class 1A PRAME negative patient who develops metastasis in like 2 years. And it happens, it's 2% on the biosciences report, and maybe that accounts for it, but all of us seem to have it. So we do sort of tell our patients that, it exists. These tests are not perfect. It gives us a great sort of idea of their risk profile, and we're doing the best we can, but it's really not sort of set in stone is kind of what I tend to discuss.
Just one comment. You showed the paper, which actually I didn't know about this paper, but I was telling my patients, I keep a track a little bit of I keep track of my patients, but I look at, they say, and they have on average, the literature says that 50% of patients with uveal melanoma are supposed to develop metastasis. And with class 2, it's like 70% will develop metastasis. I say, I don't know, there might be something in the air in Southern California, because my practice is more like 25% of people develop metastasis. And the class 2 is worse, but it's not like 70%. But I think this is what you showed, when it's not only our experience, when actually there might be over-reporting, or something, people with higher risk disease or something, but then this risks might be slightly lower than, the tests are reporting.
So it sounds complicated. Luckily, we have AIM to help sort this out for us too. And, there's still some more questions, but we're going to take a break now and be back in 10 minutes. So thank you. And we'll zoom back in 10 minutes.
And then they're just all up here.
Okay, we are mainly back and we'll get started. The second half, Dr. Dowd's going to lead us off looking at kind of where we are and where we need to go and what are the tools that we have for that. And then Dr. Park is going to come up and help kind of field questions about kind of current state as well as possible new stuff. And then lastly, we'll have Samantha come back and wrap us up with some closing remarks. So with that, I'd like to bring Dr. Dowd up. And Dr. Dowd's been at UCSF for several years now. Really enjoyed interacting with him over the years. He's been a good mentor for bouncing things off and thinking about where we want to go. And he's been a leader at the UC Melanoma Skin Cancer Consortium. So thank you, Dr. Dowd, for doing this. And I can't see the mouse. There it is. Oops. Okay. Perfect. Okay.
Thank you. I'm excited to be here and excited to be part of this great program. Thank you, Dr. Daniels, and thanks to AIM for organizing this and Paige. So yeah, let's see if I can figure out how this works. But yeah, so and it was great to hear Dr. Chmielewski and Scott and Lyndon too today. But what people think today is that the way anti-tumor immunity works is that there's a process where your immune system senses cancer. And it isn't, I wouldn't say that it's totally clear how that happens, because as Dr. Chmielewski was saying, there's differences between cancer and between your body, but it isn't totally clear what needs to happen for your body to sense that. But we think tumor antigens play some role. Those tumor antigens, are shed and they're picked up by dendritic cells. These are cells in your skin and in the rest of your body that sense changes in your body. And then these dendritic cells then basically go to the lymph nodes. And then at the lymph nodes, they essentially just lie in wait, sometimes for years, waiting for the right T cell. And remember, each T cell only makes one kind of T cell receptor or one kind of antibody in the case of B cells. So you basically are waiting for that match to happen in the lymph node. And sometimes that takes a while, but once it happens, the T cells get activated, they go back into the tumor. And then once they go back in the tumor, they start killing tumor cells. And so what we've learned over the last few years, that if you look, for example, at the response of different types of cancers to immunotherapy, it does seem like there's a certain level at which most cancers will respond to immunotherapy. So like, for example, if you look at skin cancer, if you look at squamous cell, basal cell, melanoma, Merkel cell, they all have this around like a 40% response rate to immunotherapy. And if you look at kidney cancer, it's about 20%. If you look at lung cancer, it's about, maybe 15 to 20%. And then if you look at the very extreme end here, like prostate cancer, pancreatic cancer, it's low. It's not zero, but they don't often respond to immunotherapy very well. And I think where we stand today with immunotherapy is informed a lot by this Checkmate 67 study, where basically patients with melanoma were randomized to either nivolumab plus ipilimumab, that's the orange box, versus nivolumab alone or ipilimumab alone. And basically that's where we stand today. That if you look at the combination of nivolumab and ipilimumab, it's about 52% or about 50%, even out to 6 years. And as Dr. Chmielewski was saying, basically we are talking about this space here at the top, where if you had 100% survival, you'll be here. And we're talking about the 50% of people who don't have a response today with combination immunotherapy. And if you look at different types of melanoma, not all respond as well to combination immunotherapy, and some respond better. Like, for example, if you have wild type BRAF, so non-BRAF mutant melanoma, seems like you do just about as well from just nivolumab or nivolumab plus ipilimumab, while if you have a BRAF mutant melanoma, it seems like you get some benefit, like maybe about 14% from the nivolumab plus ipilimumab combination. And if you look across the spectrum of immunotherapies, and if you just look at what price are you paying for your response, and in our jargon, that's called side effects or grade 3 or 4 side effects. So the higher you are up here, the more you have autoimmune side effects like lung inflammation, skin inflammation, liver inflammation, etc. And the better you're at this end, the more effective the immunotherapy is. So you could see that there is a general trend that the more effective the immunotherapy, the more side effects you have. But it isn't like a perfect, kind of like a, regression. Like you could definitely see that, some types of treatments, like for example, this combination of relatlimab and nivolumab, you could see that you could get pretty good responses, but you're not getting a lot of side effects with that. While over here, you're getting, with Checkmate 67, with Nivo-Ipi, with the high dose Nivo-Ipi, you're getting pretty good response rates, but you are also getting 50 to 60% of people developing severe side effects. So in some cases, I think you're paying a lot for the side effects, for the response that you're getting. And in general, the more PD-L1 staining you have, the better your response is going to be. And this is a study from several years ago. But if you have a tumor that has a lot of PD-L1, like right here, the response rate is going to be 50%. While if you have a tumor that's here, 0%, you're going to have maybe 10% response. So like Dr. Chmielewski was saying, it's not like 100% concordance, and it's not like a red light, green light kind of thing, but there is some relationship between response and between PD-L1 staining. And it's also known that it's not just the tumor. It doesn't even matter what the tumor is. Regardless of the tumor, there's factors that are known to affect immune response. Like, for example, things like obesity, age, microbiome, what kind of gut flora you have, your gender, the bulk of your tumor, how big the tumor size is, that informs the response rate. And, back a few years ago, we looked at things like liver metastases, and we looked at the centers on the West Coast, UCLA and UCSF and Angeles Clinic. And basically what we found is that the presence of liver involvement and we're talking skin melanoma, so we're not talking uveal melanoma, which is known to have a predilection for liver involvement. But even in skin melanoma, if you had liver metastases, things were less likely to respond to immunotherapy as compared to if you didn't have that. And if you look at what are known as spider plots, so basically each of these lines is one patient, and these are patients these are many hundreds of patients who were treated with PD-1. And if you look to see how their scans evolve over time, you'll see this general pattern. Like, for example, if you look at this paper, Clinical Cancer Research 2017, each of these is a line. And for example, if you look at most patients, they'll either have a response in the first few weeks of treatment or not at all. It's rare for somebody to have go along this way, like this patient here, who went along with no real response for about 15 months and then suddenly had a response. That is not the common pattern. The more common pattern is have a response and then gradually it gets better over time, or else to not have a response at all. And I feel like you could divide the responses into these stages. Like you have this initial ignition stage, and then over time it can get more complete and more, more stronger. And then if you watch those patients for years, you'll see that sometimes that response will go from like 90% to 99% to 100% over time. And that has led to this issue of how exactly that's going on and what is the mechanism behind this. And I think what best explains that, which I'm just going to cover in the next slide or two, is that you basically have T cells that fight against the tumor, but they don't have, they don't have the longevity to keep doing that over time. And you need to get fresh T cells into your tumor to complete the job. And that is like a factor in immunotherapy. And I think that's interesting when we talk about TIL therapy, where you're taking T cells from a tumor and then growing them out. That was the approval that just happened yesterday for regrowing those in a petri dish and putting those back and trying to see like how effective that is. So what's our next step? Well, there's a lot of drugs that are being experimented on, lots of interesting drugs. And I have to say that generally, if you look at all of those numbers, like for example, T cell therapy is, the adoptive T cell therapy has a, back in the day that I made this slide, had a 38% response rate. Now it's more like 20 to 30%, I would say. But if you look at the numbers here, a lot of times the numbers are not as high as it is for PD-1 therapy. And part of the reason is that PD-1 does so much of the work in response that the added treatments often will give you only like say 10% response rate or something in that range. And so where are the places where we can make a difference? I think one of the places is right here at the tumor microenvironment where, as Dr. Chimowski was saying, you can basically use vaccines and you could use other technologies to try to make the tumor more visible to the immune system. And I'd say that the even more active area of investigation is in the lymph node and at the tumor microenvironment, where we have these what are known as co-stimulation checkpoints or co-stimulatory checkpoints. And they are things like TIGIT, LAG3, CD47, and then what are known as the TNF superfamily, and that's receptors like GITR, 4-1BB, and OX40. So if you think about T cells have brakes on them. And one approach to immune therapy is to just get rid of the brakes. And that's basically what PD-1 is. That's what CTLA-4 is. That's what LAG3 is. That's what TIM-3 is. But another class of molecules on T cells, you could think of them as steering wheels. They don't necessarily brake, or they're not gas pedals, but they change the direction of T cells. And that's the TNF receptor superfamily. And that's where these 4-1BB and OX40 and some of these other checkpoints are involved. So if you look at this area right here, making your tumor more visible, as this is a trial that Dr. Chimowski mentioned. It's basically a cancer vaccine trial, and cancer vaccines, I think the long and short of it is that they haven't been successful. They haven't worked for us. They've been tested for 20 years. But looking back at them, one problem with them might have been that, we are just using off-the-shelf vaccines. We're giving the same vaccine to you as we're giving to this other person, as we are giving to this other person. And the problem might have been that we just simply didn't personalize them. And we honestly didn't have the technology to even do that until recently, until COVID. And so what Moderna and Merck have done is basically personalize those vaccines, get the tumor, sequence them, find the neoantigens, make them into an mRNA vaccine, then give that mRNA vaccine in addition to pembrolizumab, which is the PD-1 drug. And that was what this trial was. It was a 2-to-1 randomization, and this was the graph that Dr. Chmielowski showed. It basically showed that there was a major improvement compared to just giving pembrolizumab. So remember, pembrolizumab already cuts the risk of recurrence down by 40% or 40 to 50%, as Dr. Chmielowski was saying. So the fact that you're getting this added benefit to pembrolizumab is something, it's like, it's already better than nothing. So I think we'll have to see how that goes. I think one of the criticisms of that trial that I've heard before is that because patients who have a lot of neoantigens have tumors that are much more, immunogenic, you can have a situation where it's the fact that the patient has so many neoantigens that itself gives you a better response. So what happened in this trial is that it was a 2-to-1 randomization. And if we couldn't make the vaccine for you, you got put into the pembrolizumab arm. And so there could be some imbalances and there could be some issues with this. So even though it sounds like a 150 patient trial is a pretty good piece of data, actually, there's only 50 patients in the pembrolizumab arm. There was 100 patients in the vaccine arm. And so there could be some imbalances. And so now the next trial is going to have 1,000 patients. So we'll see how that pans out. And so let's take a look at some of these other checkpoints, like the co-stimulatory checkpoints. And so the one study that was presented at the ASCO meeting last year was looking at TIM3. And it's another one of these checkpoints right here. It's a brake on T cells, and you could basically take that brake out just like you can take PD-1 out. And so this was a study that was presented by Dr. Ribas, works with Dr. Chmielowski. And so this is the results from that study. And like you could see here, all of these bars going down, that just shows the percentage reduction in the tumor. And so you could see that, several patients developed responses, and some patients had some pretty major responses. And then if you look at those spider plots, you could see that seems like, even 50, 60 weeks from treatment, patients had continued to have responses. I think the one issue with this study was that patients had not, in many cases, had not received PD-1 before. So that was the problem, that we didn't, from this trial, it's hard to say how much of a response you were getting from the TIM3 blockade and how much you were getting from PD-1. So it remains to be seen, and we'll see in future trials how much TIM3 really contributes. And so the plan is to do more studies in patients in whom PD-1 didn't work, so that we could see how effective it is. And then we looked at this study, which was also opened at UC Irvine, which looking at 4-1BB, and this is our results. So these were patients who had progressed on melanoma, and these were patients who had in many cases had multiple lines of therapy, and some patients had great responses. And like, for example, this is a patient of ours who had a mucosal melanoma, and you could see that before treatment, she had this enormous tumor, like lots of disease. After treatment, nice response, and she's now a year and a half out and has a complete response. And then this is a patient, again, with mucosal melanoma, it just so happens, had liver lesions, and you could see that the liver lesions disappeared after some time. So I think one of the issues with these studies, and I think that's a weakness of this study too, is that we have to see in today's landscape, how does that fit in? Are we going to add it on to, things like Ipi/Nivo? Are we going to give it by itself? Are we going to give it with PD-1, or what? And what are the biomarkers that could predict for responses to this agent, which I don't think we know that for a fact right now. And the same drug was tested in lung cancer, and 2 patients out of 14 had responses, even though they previously hadn't responded to PD-1 before. And another interesting molecule is something called TIGIT. Again, it's one of the same, it's in that TNF receptor family. So could be like a steering wheel, not necessarily a brake on T cells. And so the TIGIT drug was developed in various settings, and Genentech had one version of that drug. And so they did a trial in lung cancer where they combined it with PD-L1. And you could see that in this randomized trial, it seemed like it doubled response rates in patients with lung cancer, and a nice advantage, over placebo. That's the blue arm. But unfortunately, when they took it to a larger trial, just like we are talking about with the mRNA vaccine, called Skyscraper 02, in a different disease setting, really no advantage in that trial. Like the primary analysis did not show a difference, and actually you could, when you look at this closely, you can see that there's a difference between the blue and the red, except that the blue is actually the placebo. So the placebo is actually better than the experimental arm. So really not showing much of a benefit. You don't want to see that type of trial where the control arm does better than the experimental arm, because that's not showing a success. And the same pathway but different drug is being studied in melanoma as well. And in this study that was presented a few months ago, it's called this Keymaker 02 study. And here, this was like Dr. Chimlowski was saying, it was like a neoadjuvant trial, meaning like you could have surgery, but instead of having surgery, you were given some immunotherapy first. And the idea was to see how your response would be. And then you would, proceed to surgery. And that one thing we could say about this drug is that it doesn't cause a lot of side effects. Like, for example, if you look at itching or pruritus, there was maybe about 10% more, but generally speaking, not a lot more in the TIGIT arm. And if you look at the response rate, which is the bottom line, if you compare this arm 1 to arm 3 is just pembrolizumab, and arm 1 is the combination. You can see that maybe you had like about a 7% more response rate compared to just the pembrolizumab alone. So we'll have to see how that translates into in a larger trial. And what's known is that if you look at pathologic response, like for instance, if the pathologist looks at the slides versus if you look at the response rates, there's some concordance between that. And so like if you look at the TIGIT arm, you could see all of these patients had responses. If you look at the pembro alone, you got a lot of responses there too, but maybe not as much as with the arm that had the combination treatment. And there's other drugs. Not totally sure why this got translated into Chinese, but I don't honestly speak Chinese. That definitely wasn't something I made, but you'll have to trust me that it's a drug that is being explored, and it is showing some promise, but we'll have to see how exactly that translates into in real life. And I'm excited to be here, and excited to be here for our second annual meeting. There's a lot of promise with different types of therapies. There's the novel mRNA vaccine technology. There's all these different checkpoints, and some of these are ready for trials. I think one of the challenges that we've had is that without today, there's just so many drugs out there and a limited number of trials that you can consider, and you have to be able to predict somewhat who is going to respond to what type of treatment before you start doing that. We haven't even talked about targeted therapy, which is a big feature in our disease. There are NRAS inhibitors. There's the inhibitors for uveal melanoma that Dr. Chimlowski was talking about. But in addition, there's a lot of immunotherapies. And it's almost a difficult thing to decide who to treat with what type of immunotherapy. So with that, I'm going to end and
Okay, great. Thank you. Okay. And I'm going to stop sharing. Gonna move the thing and invite Dr. Park up to field some questions and to pepper us with hard challenges.
Good morning, everyone. Thank you for joining us. If I could also invite Dr. Chmielowski to sit with the other medical oncologists. So I thought I'd first start off the roundtable talking about a new therapy that was approved just yesterday, and then we can take some questions after that. So yesterday, the FDA approved the first and the only one-time cell-based treatment for a solid tumor by Iovance Therapeutics, known as Amtagvi, and this is otherwise known as lifileucel. And what is cell-based therapy? I just want to briefly mention what it is before I direct some questions to our experts. So when your body develops a cancer, your body's immune system creates a special type of white blood cell called a T cell, that is also known as a tumor infiltrating lymphocyte, and that's where the TILS abbreviation comes from. And the name of the T cell explains to you what it does. It resides in the tumor because it is able to recognize the tumor and try to attack it. So this treatment is for patients who have had their cancer progress after receiving a certain type of immune therapy called PD-1 blockade. Or if you have a BRAF mutated tumor, you've already gotten drugs that target the BRAF, or you've gotten BRAF drugs. So this drug, essentially, you would need to see a surgeon, and they take a piece of your tumor out and they send it to the lab. At this lab, there's a standardized process where they're able to find a special type of tumor infiltrating lymphocyte. And there are not that many of them in the tumor. So what the process does is they're able to extract this white blood cell out and treat it to make billions of cells. And then we take those billions of cells and infuse it back into the patient. But before we actually infuse it back into the patient, we give the patient special type of chemotherapy to deplete their body of the T cells that they already have. And then we give them this special type of T cell therapy that was developed in the lab. And then we give them another type of drug called IL-2, which is a cytokine, which helps the T cells that we infused back into you to expand and grow so they can go and attack the tumor. So questions that, now we have, this is a very specialized treatment. It can only be given at an authorized treatment center. And I'm lucky to say that we are one of those sites, and there are others throughout California and the nation. But, what was this FDA approval based on? And, which type of patient is this most appropriate for? How much does it cost? What does it look like to get this treatment? How can patients get it? And so I'd like to first talk about what the approval was based on and who is most appropriate, and I'll direct it to Dr. Daniels to start off.
Okay, thanks, Dr. Park. Yeah, I'll just reiterate that this is a really amazing time in science, as Dr. Dowd's slides overwhelmed us with all the possible targets that we're looking at, and Dr. Chmielowski, and treating earlier. So we got another tool yesterday, and that was a product. It's a living product. It's a product from yourself. So as Dr. Park said, these tumor infiltrating lymphocytes go normally into the tumor, but they're not doing the right thing, obviously, because the tumor developed. So taking the tumor out, isolating those cells that recognize the tumor, and then stimulating them to want to do the right thing and giving them back. So needless to say, this is a complicated process that involves surgeons selecting the right patients for it. And as Dr. Park asked, how did this come to be? How do we have this approval? And as I mentioned in the beginning, I really have to always give credit to Steve Rosenberg, who pioneered the idea. did trivial things along the way, like figure out that you need IL-2. So, developed interleukin-2 as part of the process. And had at the surgery branch specialized units to handle this. And that was good and challenging because those specialized units dealt with the complications that they were having during the optimization process. However, one of his goals was always to try to make it as simple as possible to get it out so the rest of us mere mortals could do it too. So Iovance came along and developed a commercial process. And through that, as you've seen, there's clinical trials. So early clinical trials showed the feasibility of it, showed the safety profile of it. And then what the FDA has been mulling over for this last year has been their larger trial looking at patients who have failed all other standard therapies, who have a tumor that's resectable and are healthy enough to undergo this process. And that's what the approval is based on. That's not the only study out there. And about a year ago, another study was published looking at this in Europe, where a larger group of patients were randomized to the cells or other immune therapies. In this case, it was ipilimumab, and showed an advantage for patients who got the cells. So there's lots of issues, but that's what the next questions are going to be about.
Can someone touch upon what does it look like to get this treatment? Because this treatment has to be given in the hospital.
Yeah, so actually, do we know what the price is or not?
It's $515,000.
Oh, you do. Okay, that's right. So it's in the range of CAR T-cell. Okay. So one thing which you didn't mention is there's another step which is required for this treatment is high-dose chemotherapy. So this patients, what was in the development of this, because we were asking question, if the cells are sitting in the tumor and they are there, but the tumor is still growing, so they are not doing their job. So what would be the function to take the cells when they are not doing their job to give them back to the patient if they already didn't do the job? And one of the function is when, as we talked about it, our immune system generally is designed not to get rid of self, get rid of something that does not belong to our body. So tumor uses this, not that it's so smart, but otherwise wouldn't be surviving, is when if the cells get there, try to get rid of the tumor, say, oh no, I belong to your body, don't get rid of me. So by suppressing, you have to get 5 days of chemotherapy before. And there were studies showing the more suppression you give of your own immune system up front, the better outcome you will get. So if you just sprinkle somebody with chemotherapy, with the cells which are infused will face the same defense mechanism and say, oh, you don't, I'm here, I belong to this body, don't get rid of me. So you have to temporarily suppress your immune system with chemotherapy, then the infused cells. So this also leads to that when people who might have poor heart function, poor lung function, poor kidney function up front might be not very good candidates because might not be able to tolerate this chemotherapy. It's only one-time treatment, so it's not like a repetitive. Then we exactly don't know in the commercial setting how fast it will be to generate the cells. So it means you come to your doctor, says, you got your scan, says, oh, the previous treatment didn't work, we have to come up with something else. Maybe the cell therapy would be the right treatment. You have to go to a surgeon who will schedule your surgery to remove this tumor. Then the tumor is sent to the lab, and then the cells are produced and you have the cells frozen and ready for the mission. There is one step which is unfortunate, but it's an insurance authorization. Actually, I just read, and I think it was in JAMA, one group looked at the outcome of patients with kidney cancer. I'm almost sure it was kidney cancer. And they looked at the outcome of patients, how long it took the patients. They got the same therapy, but some people got so long, or maybe it was CAR T-cell, but it doesn't matter. But they took so many days to authorization, and another group of patients took fewer days to authorization. The shorter time to authorization of treatment, the better the outcome of the patients in the study. So we don't know what's going to happen, how long we don't know because we haven't faced. Maybe my fears are completely unjustified, but as you identify the patient, you will submit to the insurance the authorization process. So you will have to create this team of people who will work on it. Each of our centers are, probably doing their own thing, how we do it. We'll see, we have approval right now. We'll start trying to see how fast we will be able to get the process going. So if you have a tumor that needs therapy in 2 weeks, otherwise you'll be in big trouble. You might not be ready in 2 weeks for this cell. Probably you have to think that you have to be a patient who can wait two months, maybe 3 months before. We'll see. As we get better, probably this process will be faster. So those will be few factors which will be adding. Also, I have to say, it's a wonderful therapy. We are excited to have it. But when you look at it, very few people get cured with this therapy. So I don't want to overpromise, people live longer, appears, but really the cure was provided in the trial maybe to 5% of patients. It doesn't mean that, so it means the majority of these patients will need the next line therapy after that, So I don't want to say, that suddenly, because people say, oh, if I don't get it, then I'm not going to get cured.
So we have a question in the chat that I'd like to direct to Dr. Dowd. So is this TIL-based therapy, can it be used in patients who have melanoma that does not have a BRAF mutation?
Well, it can definitely be used in patients who don't have a BRAF mutation. And I guess I would just say that, I always think of what happens if the treatment doesn't work. And and I guess my concern a little bit with this is that if you do it at an early stage, and let's just say your chance of responding is like 25%, but which means that 75% of the time it doesn't work, what happens to those patients? And at least my experience, which may be biased, just based on what kinds of patients we've been seeing, it's difficult in that patient to try different types of therapies. I mean, like we were talking about just a few minutes ago, there's almost too many treatments to try. There's just all kinds of permutations and combinations, and we expect more approvals in the next few years, more types of treatments. I try hard not to do something that reduces people's chances of responding to something else in the future. And if you're going to get a short duration of response, but it's at the price of, conditioning regimens and just as Dr. Chmielewski was saying, side effects, there's a certain chance that you burn out your bone marrow. I worry about the future in those patients, and we've had some issues with treating patients like that with other types of treatments in the future, because your counts aren't adequate, and then that can prevent you from trying new stuff. And the other point I'll make is that, we're talking about the BRAF mutations. It's hard to know what the right patient is for that, because, unlike PD-L1 status, which, you could criticize PD-L1 because it's not perfect, but for adoptive cell therapy today, we don't really understand who responds. And, clearly it's not the person who's just stepping off the curb. I would say that's not the right person to try. It's probably not the person who has a BRAF mutation, because that person has various other options too. But it could be somebody who is maybe one of these types of melanoma, like the acro-lentiginous melanoma that doesn't respond so well to immunotherapy. It could be there could be classes of patients for whom it's the right thing to use.
Okay, thank you so much. So I'm going to take another question in the chat. I'll direct it to Dr. Daniels. So for patients who have had a good response to immune therapy and are currently off treatment, in the future, if they were to recur, would it be more appropriate to go back to what they were treated with before, or should a new treatment plan be pursued?
Yeah, so I'd like to make it an easy answer and just say yes, but it's complicated. So if you had a good response to a particular therapy and tolerated it well and got maybe a year or two before he had to deal with melanoma again, it usually makes sense to go back to that therapy. And there's pretty good data to support that. Thank you, Paige. But, therapies are also changing. And a big part of choosing therapies is thinking about the other side, the dark side, the risks of the therapies. And when we do, for example, combination therapies that are currently a standard of care, it comes with a pretty high risk for having some side effects. So as we learn more, it's possible that retreating with the same stuff makes sense, but also maybe we've learned enough that we can move you on to a different therapy that has a better safety profile.
Thank you. So I'll direct the next question to Dr. Dodd. If you could hold the mic closer to you when you speak. So do older patients have more severe immune-related adverse events?
Is the question that do my patients have more severe adverse
No,
events?
do
Older.
older.
Yes, it could be that I'm really creating more severe adverse events, but older patients, I think that my experience has been that younger patients have more severe adverse events and more women have more significant. And I think that's what the literature shows too, that, like 4 out of 5 autoimmune disease patients are women. And I think generally goes along with my experience, but I mean, definitely there are men who have, and then younger people and older people who have more severe adverse events. But no, I think years ago, like in 2012, if you had asked me that question of who responds well to immunotherapy, I would have said it's the young, healthy person. But time has shown otherwise. It's basically older folks who have great responses to immunotherapy. And maybe it's because of the types of melanomas that they have. But yeah, I think that, to my surprise, it's often older folks who have great responses to immunotherapy. And I have to say that, there's this question in our field, whether you should always use combination immunotherapy or whether you should sometimes use single agent. And I personally think you can often use single agent immunotherapy in older people, not because you're scared of the adverse events, but more because you can get a great response to many of those patients with single agent immunotherapy. There's no reason to put them through the side effects of dual or multiple combination immunotherapies.
Yeah, I agree. It might be kind of paradoxical, but I think older patients do better. And it might be because of the type of changes they have in their melanoma. It's a different group of patients, a young person versus an older person. And also in Southern California, you do have less side effects. Would you? Yeah.
No, so yeah. So I tell when I talk to my patients about it, generally age is not a risk factor for side effects, and we should not exclude you from the treatment. Of course, the best example would be Jimmy Carter, who had brain metastasis and is still alive. And well, I know, we know that he's under hospice care, but not because of melanoma, but just because of his general age, So what I tell the patient, when for older patient might be more difficult to deal with the side effects. So the risk might be the same or maybe even lower. But if a younger patient has bad diarrhea with 10 bowel movements a day, they can easily drink. If somebody is dependent on a walker or so, maybe they get dehydrated more easily, just not by the fact that they had to replete water and so on. So this is a little bit, but I don't hesitate. I think my oldest patient I treated was 99 years old, and he actually had a complete response to the treatment. So yes, you can treat.
I'm going to direct the next question to Dr. Dowd because of your particular interest and also some of the work we are doing in the consortium. So for patients with metastatic melanoma, is there anything that can be done to prevent the development of leptomeningeal disease?
I think that's a great question. And it's one of those, it's one of those issues that we haven't talked about yet. What can happen is that melanoma can spread to the brain. And in rare occasions, it can get stuck in what's known as the leptomeningeal space, and that can be very hard to treat. And so far, the response rates to treatments are really low. People often, again, it's an evolving area, but I'd say that, patients often have only a few weeks to live after that. But one approach to that has been to try to put immunotherapy directly into the leptomeningeal space. And we're, through our consortium, we've proposed several trials, and we are hoping to carry out a trial where we put two of these immunotherapies directly into the leptomeningeal space, into the CSF, using a special kind of reservoir called an Ommaya reservoir. And in an earlier version of that study, we did have some responses in patients. So we're hoping to take that approach. And I think another area where which we are actively investigating is the area of refractory brain metastases. Back in the day, the general approach for patients with brain metastases was to use something called whole brain radiation. Now that is, pretty toxic, and we try to avoid doing that. And immunotherapy has been a big success in terms of patients with brain metastases. But there's a lot of patients who initially respond and then stop responding or never responded at all. And I think one of the things that Dr. Park has talked about is using this type of, immunotherapy approach. And maybe I should let you talk, Sue, about.
No, I'll let you go ahead and talk about it.
It's a very difficult situation to treat if people have spread to leptomeninges. Because, on one side, I'm not very optimistic when we have to work on it and see how much we can change it. But when you think about it, philosophically or something, if a melanoma travels through the bloodstream and it goes to the liver or lungs, so your patient develops metastatic disease. It travels through the bloodstream. So blood gets to any part of the body. So why did it grow in this patient in the liver, and this patient in the lung, and this patient in the brain, and this patient in leptomeninges? It tells us also that it's not only the treatments you use, but also the features of this patient's particular melanoma or this patient's particular body. So the features of cancer, so there might be a pre-existing feature in the cancer that makes you, then this one will go to the liver, but this one will go to the brain. This is not completely true what I'm saying, but these features you will not be able to change because this is the feature of your cancer. So sometimes people, unfortunately, we try to do it, and we have it. So let's hope we have to understand why this melanoma in this patient went to a leptomeninges and this one didn't, although the blood gets to any part of the body. So potentially the cells can go to any part of the body. I don't think we are there yet, but I think these approaches are very interesting. We'll see what happens, It's luckily somewhat, the problem is also like this, that our patients live longer and longer. Because they live longer, that's what we want. But because of that, they have higher chances to develop spread to the uncommon locations, which before we didn't maybe see it so much because they didn't live long enough to develop spread to uncommon locations.
Yeah, often we get asked, what therapy should I take? What's the best therapy? And as you have pointed out, it really depends on where the disease is, what the cells are doing specifically. With leptomeningeal disease, we like to avoid radiation, but sometimes, unfortunately, you have somebody who's very symptomatic. They're on steroids. They can't tolerate immune therapies. They don't have a mutation that helps us. So there's all these factors that go into kind of making a decision for a plan for them. But we definitely, and hopefully through the consortium, need to address some of these areas that aren't getting enough attention, but continue to develop as more and more patients are living longer and longer with melanoma, and we're seeing more challenges.
Another thing which I was generally thinking is a little bit different is I think there's a place for artificial intelligence in this, because what's artificial intelligence? Of course, a computer system, it's a software and all of this that analyzes the data, comes up with a result, and you say, can write you an essay, can do this. One of the things which we miss or kind of lose in this clinical trials, we see where patients is enrolled in clinical trial. It means that this patient met particular, each trial has inclusion, exclusion criteria. They didn't have, whatever it is. So these patients are somewhat selected. And then you have responders, you don't have responders. And then the drug is approved, and we try to apply this knowledge to this particular patient who sits in our office in a chair and say, okay, this is the therapy for you. But realistically, we cannot account for all variables, which may the age, the comorbid conditions, the features of the cancer, how can they contribute? And one thing which we don't have very good, we don't have databases of outcomes of patients, so this would be wonderful. I mean, artificial intelligence can be very successful, but will be only successful if a database from which it's resources is very broad. Because if you have a database of 50 patients and you try to do recommendations for everybody, this will be very limited. But if we had a national database that we could enter the information about the patient, the outcomes on the therapies, and then use the artificial intelligence to give you recommendations, I think this would be something interesting, This is just completely.
Thank you for that comment. I'll direct the next question to Dr. Daniels. So can patients with mucosal melanoma get access to TIL-based therapy? And what is the data in this space for TILs?
Yeah, that's a good question. Trying to select the right patient for TILs. Most of the patients on the clinical trial were cutaneous in origin. There have been studies looking at mucosals and uveals, and we do see responses, but there's not as big a data set. Actually, I'm not sure the label is going to distinguish, and maybe you can pull it up since the label just probably came out yesterday, because some of the drugs, some of the medications, when they got approved, they were studied primarily in cutaneous melanoma, but when the FDA made the indication for it, they just said melanoma. And that's given us, new tools in rarer melanomas, but it's also, there's a lot of information we don't know, what is the response rates, and we have to figure that out later down the road. I suspect this is going to be the case for TILs. Probably, I don't know if they got cutaneous melanoma as their label or melanoma as their label.
I mean, I think while we're looking at that, I think an analogous situation is in uveal melanoma, where there's some data that TILs do work, and that there's some response rate, right?
Yeah.
Which might be like a place where they could be tested, or might be a place where they could be augmented, maybe.
Well, TILs is a really interesting tool because really the current TIL product is what we call TIL 1.0. TIL 2.0 is going to be really identifying maybe more specific cells or different stimulation, or looking at that lymphodepletion that Dr. Hamilowski was saying is necessary. How much is really necessary? Can we use other things? There's so much to expand upon, and then into other tumor types, because probably we should be able to figure out if there's a way to make T cells kill breast cancer more effectively. Maybe, that would be until 3.0. So it's going to provide a platform for discovery, I think.
It's definitely a lot of good data in that TIL product. But the one, again, additionally, one of the issues with TIL is that we don't currently know what the survival is, and we don't know, and part of it is to what Bartosz was talking about, like just the difficulty of doing trials with TIL, because, you've got to have a patient who can wait for a month or two before you can get the TIL product. So that makes it hard to do comparative trials. I think the trial that was done in Europe, the John Honan trial, where it compared TIL to ipilimumab in the second line setting, we don't really use ipilimumab in the second line. You know, somebody who doesn't have a response to PD-1, we don't usually, here we use ipi-nivo. And my understanding is that they did the trial comparing it to ipi because in Europe, that's what's common. But interestingly, in that trial, there was no survival benefit versus ipi. There was a progression-free survival benefit, but no survival benefit. So I'm looking forward to seeing some survival information in the years in the future. You know, maybe that's a place for us to do trials, look and see whether there is a survival benefit. If you know, that would be the gold standard.
I'm going to keep the mic to Dr. Dowd for the next question. So for patients with stage 4 melanoma, are there children at higher risk of developing melanoma?
I mean, I think there's familial, like Dr. Linden was talking about, there's definitely some familial syndromes, you know, with, there's familial syndromes with where, you know, the same kind of predisposition can be present in your children too. And so I think now I personally am an advocate for testing because there's a company called Color, and then there's another company that does testing. I'm blanking on their name, but it's only $250. You can basically do a saliva or blood test, and it doesn't tell you about every single genomic abnormality, but like the BRCA and the some of the P16, some of the CDK, you know, it can help you with that. And of course, I do think that patients who have melanoma, even if they don't have those genomic abnormalities, should probably counsel their kids to have dermatology evaluations and stuff like that. Because for one thing, I feel like there's no risk to it really. And secondly, I think that, you know, there's environmental, like it could be that you don't have a genomic susceptibility, but maybe you're just fair skinned and you know, you're hanging out at the beach a lot. And maybe that's the thing, the environmental, you know, you might share that in your family.
Yeah, I agree. Most melanomas are not, we can't find that gene. But the technology is getting so accessible and the cost is low that you can go get these screens. I will say there is toxicity of seeing a doctor. Yeah, well, not to be funny about it, but and a lot of our friends are dermatologists, or maybe not anymore after this, but so you know, going in and getting a skin exam seems like a pretty simple thing. The U.S. Preventative Task Force actually currently discourages that, and it's really controversial as to why. But one of the things is just taking that 3 steps back and looking at, are we benefiting the population with the resources that we're using to do that? And so certainly C-spot change, see a dermatologist, ugly duckling. If there's a family history for melanoma, there needs to be family awareness and again, applying those rules. If there's a high history of breast cancer or pancreatic cancer or some related tumors or multiple melanomas, they're off to the dermatologist too. But there is some toxicity to CNS.
Yeah, no, so I think this is very important, because generally, of course, if you advise one patient and say, yes, please go and see a dermatologist. So one of the features is, as I mentioned, we rarely find the genes, but because the children come from the parents and they have, so if the parents had fair skin, very often children had fair skin. If the parents were red-haired, the children might be red-haired. Not always, but they have freckles. These are all the risks. So it is not very often not one particular gene, but the combination of the genes. And you know, when we pass on our children, and very often they develop in the same environment. Maybe right now there's more migration, all of this, move from north to south and all of this to sun exposure. So these tests are not able to find the combination of genes that puts you at risk. So I generally say, yes, be vigilant and maybe your children should undergo visit with dermatologists. But when you think about it, You go to a dermatologist is under pressure, also under pressure that, oh yeah, the patient had cancer, the mother had cancer, had melanoma. I need to start biopsying all these lesions. Then you start generating costs. And then you have, on once in a while, you found some atypical lesion, might be cancer, might not. Then you is referred to surgery. So these are the things which is toxicity of sometimes overdoing the things, So how to find this balance? Yes, you go, but if you do this to millions of people, you will start seeing side effects of your referrals, because there will be procedures done for no reasons, there will be costs, there will be this. If you do scans for the lungs for lung cancer, yes, you can detect lung cancer nodules early, but you will also detect nodules that are not cancerous. You start going for surgeries or biopsies. There might be even, although they are generally safe, if you do it to 1 million people, there will be side effects, there will be toxicities of these procedures because they are associated with risks, not saying costs also. So this is always so difficult with all these recommendations because yes, do everything possible, do as much as you can, but sometimes for population, for society might not be of the biggest benefit.
It's crazy.
It is.
So, we may not know that gene now, but we may know it later, and that's why research is so important. But going back to the mucosal question for TILs, we did some research and it does not appear that the label limits. So mucosal patients should be able to access TIL therapy if they are appropriate per their physician. So with that, thank you.
Let me tell you one quick piece of which maybe the general audience is not aware of it. Insurance company use the codes and the diagnosis codes. So actually, let's say uveal melanoma in the system is coded as a cancer of the eye, not as a melanoma. So because the code is for eye cancer, none of the immunotherapies are approved for this particular code. I shouldn't say it loud, but I'm saying it's another part of the face cancer, then melanoma of another part of the face, and then it gets a melanoma code and you can do it. This is reality.
Well, we keep fighting the good fight, so.
Yeah, the insurance companies are calling you later.
So I'd like to thank the panel for their insights, and then I'm going to turn it back over to Samantha.
So I know everybody's rushing to the door as soon as I'm done. So I just first want to thank the UC Consortium. It is always a pleasure. The fact that we had so many questions and still other questions, I think only shows how interested people in the melanoma community want to learn, and how helpful hearing all of your presentations were incredibly important and useful. And now, being part of that shared decision-making starting today and going forward. I do always want to take a bit of time, though, to share with you not just what brought me personally and professionally to this point, but what we are doing to support the entire melanoma community. Today, specifically, though, I'm going to talk about patients and families and some of the other resources that we have for you. See if I got it. So we talked about a number of different treatment options that are out there, and I strongly believe that one of the goals and one of the things that is most helpful in improving overall survival is recognizing and managing the side effects of your treatments. So other than TILs, because we just got approved, but for the other treatments, at least for now, we have side effect management guides in order for you to bring to your healthcare provider and to have questions about how to recognize them. And quality of life, of course, is of high importance. We are very lucky to have a physician assistant who specializes in melanoma, who's there to answer your questions. So if you didn't get your questions answered today, or if you've got other ones going forward, please feel free to reach out to Melissa. It's a free cost. Clinicals still are a high importance for melanoma. We've got a matching service. I'm going to jump down to from the clinic to the living room webinars. So these are webinars that are hosted by Melissa that address various medical issues that people in the melanoma are facing every single day. Jump back up to beyond the clinic. Emotional well-being is just as important as your physical well-being. So we are very fortunate to have a podcast called Beyond the Clinic, which is hosted by Dr. Liu, the Director of Cancer Survivorship for Kaiser Permanente. Melanoma 101 videos. You know, there's a lot of stuff out there, and needing to know the basics is really important to understand the more complicated stuff. So again, that's provided by Melissa. Melanoma stories, survivor stories. Hope is what gets us through all this. So we have survivor stories, and we encourage you to please participate. I'm actually very fortunate to get to meet a couple of you personally today, but we have a peer-to-peer support program where we are matching newly diagnosed to what we call veterans in this space for caregivers, patients, loved ones. And then there's our Steps Against Melanoma walks, which again, we work with the consortium on. As I indicated originally, our main focus when we started this foundation is to find a cure and research. And that is the point of our Steps Against Melanoma walks, is to raise funding. If you have any questions about any of these programs, Anne usually is here in person. She's on the East Coast, so I want to make sure you got her information. And I actually do want to bring your attention to a new website that we launched just last month. We are very actively involved also in the non-melanoma space for a number of different reasons that I won't go into, but there is a lot of individuals who are have melanoma, and therefore also have other skin cancers. We heard some of those questions today, or no loved ones. And so we have our aim@skincancer.org website. It has some of the same resources. It's we model it after melanoma. So we discuss skin cancer prevention. We primarily focus on basal cell and squamous cell carcinoma, diagnosis, staging, treatment options, along with side effect management sheets for those treatments that are approved in those skin cancers. We have a number of, again, other resources. We have Ask a Skin Cancer Nurse, Krista Rubin, who is from a center back east. She helps us with those. She has her webinars that are starting, our virtual symposiums, another something else we do with the UC Consortium as well, survivor stories and more. Jumping to a skin cancer image database is probably one of our most popular pages, a clinical trials matching service. We do have an entire section on skin cancer and skin of color. We discuss a number of different things. We've actually worked with somebody from SOX in this field. We have images that we are continually adding in that section. And then again, skin cancer related stories, news articles, and so forth and so on. So I certainly want to encourage you to utilize that resource as well. And then, of course, I had to highlight one of our skin cancer webinars that's coming up. Dr. Park, who we all saw just a few moments ago, she was gracious enough to help us participate in that one. And she's going to be discussing a multidisciplinary cancer care, what it means and why it matters. And so that is coming up next month and will be live virtually. And if you have any questions, again, please do not hesitate to reach out to me. It is always a complete honor to speak with each and every one of you. I know sometimes it takes me a bit of time, but it is why I continue to do the work that I do every single day. Thank you. You want to say a few words and then?
So thank you, Samantha. And thank you for all the speakers coming down and the people that came in person and all you Zoomers out there. And you know, I don't really have much more to say other than if you came and saw today, then you have the information that probably 98% of the people in the world don't have. So please go out and share the information, because that's how things get better going forward. So I want to just again thank everybody.